Good morning and welcome to our workshop on basic mechanisms and processes that either influence or hinder the self-management process. OpNet is a trans-NIH initiative that tries to fill the gaps and bridge the institutes. And under particularly NINR's leadership, we have made tremendous strides in understanding why people can manage their chronic conditions better. What we know less about are those internal mechanisms under the skin, whether they are psychological processes, group ties, and biomarkers that, of course, are linked to all of those behaviors. And so we're coming together to understand how those processes happen better, to look for a research agenda for the future. Our new director, Bill Riley, is very interested in this meeting. Unfortunately, well, the good news is that he has gone from our acting director to our appointed director. And once that happened, his calendar filled up and he was taken out of the country on agency business. So he sends his regrets. And my deputy director sends his regrets from his car on the Capitol Beltway. But I have an even better guest introducer after I tell you, one, that demand and interest in this workshop comes from across the country and across the world. And so we are video casting live. And I will be tweeting all day. You are welcome to do so as well. It's on the cover of your meeting folder. And then if you are so inclined during lunch, you are welcome to take a break because you'll be thinking and talking all morning. But if you'd like, I will turn to our Twitter account and entertain questions from people who are following along. First, though, we have an esteemed surprise guest to welcome you, Dr. Patricia Grady, the director of the National Institute on Nursing Research. Pat, would you mind coming up and welcoming everyone?
Thank you so much, Bill. It is my pleasure to be here this morning. As Bill said, this is an area that we have a great deal of interest in and have done pioneering work in, from self-management of teens, helping teens manage their diabetes throughout their life, to elderly Hispanic women engaging in self-management for difficulties, pain, and mobility limitations with arthritis. And so we have a wide range of interesting research in this area, but we also are excited about it because as you look at our population across the country and across the globe, people are living longer to develop chronic illnesses, but they're also healthier despite that. And they're very informed and want to help manage these the chronic illnesses that they have and live very full, high-quality lives. So really, where we can be the most help is to help people to be able to manage their own issues. And when we look at the wonderful research that is being done across the NIH and across the country, and look at the results that can promise so much for people to live a better life, those results will really only be meaningful if they are incorporated by people into their lifestyles. And so that really is what self-management is about, largely. So we're excited. I'm looking forward. The program today looks just outstanding. I'm looking forward to hearing as much of it as possible in person, or like many of you on the phone and at the distance. I may be joining you later this afternoon, but rest assured I will be hearing all of it, and I'm looking forward to it, as I know all of you here in the room and across the country and even the globe are as well. So thank you very much. I'm going to listen and learn.
So good morning, everybody. I'm Donna Jo McCloskey, and I'm a program director at NINR in the self-management branch. And I am excited to be here, and I'm so honored today to provide you with a short welcome and set the stage for today's activities. So in looking at self-management, you might think about, well, I'm not used to this slide thing here.
Do you want me to
Yeah.
read the slides while you talk?
No, I'm good. I'm good. You can read it here and then also see the slide, your next slide, so it's confusing me. In looking at self-management, you might think about how important your own health is to you. We all have different degrees of self-management, if you think about it, and you think about your families. As a researcher and a clinician, I always ask myself, why are there people who are committed to self-managing, and are better at it than others? What is the trigger? What is the drive? What is the makeup of these individuals and the successful self-managers? Self-management is a dynamic process in which individuals, in conjunction with family and others, actively manage their health conditions. And at NINR, along with other ICs at NIH, we support self-management and we support these efforts. These FOAs that you see here on the slide cover adherence, management of chronic conditions, social and behavioral research, and mHealth tools in promoting self-management. Most self-management projects focus on chronic health conditions, illnesses within the context of improved health outcomes, symptom management, complication prevention, and overall improved quality of life. We'll all agree that chronic illness is a major health problem. Chronic diseases are prolonged, have a fluctuating course, and are rarely cured completely. And think about individuals who have multiple chronic conditions. The goal in managing chronic illness is to control the symptoms and prevent disability, and also prevent worsening of their illness. Individuals must perform most, if not all, of their self-management tasks. And the patients who manage chronic conditions are at the crux of multiple social human networks, including families and other social supports, including pharmacy. Basic individual mechanisms and processes include cognition, emotion, language, memory, and motivation. Also perception, information processing, and personality types, among many others. Understanding these human aspects individually and collectively can empower researchers, participants, healthcare providers, clinicians, with intervention curricula that can personalize interventions rather than to the qualities associated with these socio-demographic categories that I mentioned. Today, we're going to explore what are the basic mechanisms that influence or impede self-management. We're going to hear about different contexts in social networks, cognition, biomarkers, caregivers, theory, and measurement. I'm so excited to hear about these aspects and from the leading experts in the field. So without further ado, we'll get our first speaker up here, Dr. Ronald Hickman, who hails from Case Western. And we have provided you with bios. So if you'd like to say a little bit about yourself, please do so.
Sorry, I'm trying to. Perfect.
And then how do I just advance? Just click.
Yes, sir. You could use nice ring.
Thank you. Just
Or you can use, if you prefer the mouse, push there.
all right. Good morning, everyone. My name is Dr. Ronald Hickman. I come from Case Western Reserve University, where I'm on faculty and as associate professor in the School of Nursing. My background as a clinician, I'm an acute care nurse practitioner in the Department of Anesthesiology at the University Hospital's Case Medical Center, where I provide care to critically ill patients and their families, which provides a great context for my research. So today I was asked to speak about the personal strengths and social context. And in this presentation, I hope to highlight the neurological basis of a personal strength referred to as decentering, and how a wearable e-health intervention for self-management can enhance decentering across these social contexts. Before I proceed, I'd like to acknowledge the generous support from the National Institute of Nursing Research. At Case Western Reserve University, we have a P30 award that is focused on the brain and behavior connections in self-management. I also was a recipient of an R15 award and a newly awarded R01 focused on end-of-life decision-making, and also received support from the National Center for Advancing Translational Sciences, and I would be remiss without acknowledging my current funding from the Robert Wood Johnson Foundation. So my objectives here are threefold. First, I'd like to provide you a description of family caregivers of ICU patients and why this is an at-risk population for early termination of self-management behaviors. And then I'd like to maybe have a discussion about brain science and self-management and particular gaps in our understanding of what brain activity and how it could impede or facilitate self-management. And lastly, I'd like to talk about a new project that I'm working on with collaborators that highlights the topic of personal strengths and contacts, targeting this new mechanism referred to as decentering. So my first objective is to really sort of paint the landscape, and my program of research is aimed at leveraging the strengths of family members across social contexts. Most of my work has focused on the development of interventions and resources to help family members of the critically ill enhance their self-management, their decision-making, and also their caregiving behaviors. Now, for a significant proportion of these family members of critically ill patients, the patient severity of the illness oftentimes precludes the patient from being a contributing member in the shared decision-making process. And so family members abruptly assume not only a surrogate decision-making role, but a caregiving role. These family members are thrust into the caregiver role oftentimes for the first time, and as a result of this new role, or the combination of being a caregiver and a surrogate decision-making, oftentimes prematurely terminate their own self-management behaviors. To enhance the self-management and avert the detrimental effects of caregiving, my team and I try to leverage the personal strength of decentering through the exposure of mindfulness-based meditation and health promotion interventions that are delivered on a wearable e-health platform. But before I jump into talking about the project itself, I'd like to just talk about why this particular population is noteworthy. Across the United States and worldwide, we're seeing increasing numbers of older Americans with severe physical and cognitive disabilities. We're also seeing a proportional increase in the usage of critical care services by older Americans as well. This exposes potentially more patients and more families to the life-sustaining care oftentimes delivered in the ICU. This slide highlights the work of Maya Zilberberg, an epidemiologist, and her work actually shows that among older adults, the numbers of those patients receiving life-sustaining care in the ICU is likely to double, to affect more than 600,000 individuals each year by the year 2020. And then for those who may not even be aware of what it's like to experience an episode of critical illness, 1 in 5 Americans are likely to die in the ICU during an episode of critical illness. And for patients who require mechanical ventilation, about 50% of those patients will die in a year. Now, this is a slide that I like to call that critical illness is kind of like the other C word, like cancer. If we compare the 1-year mortality rate associated with critical illness compared to common cancers, you can easily note that the critical illness is associated with higher 1-year mortality rates. And if we look at those mortality rates, they exceed melanoma, prostate cancer, breast, colorectal, and even lung cancer. And so this, I think, just really highlights that for many patients and families who have this context, it can often mark the onset of end-of-life care and the need for families to be much more engaged in the coordination of care. Adding to this burden and this need for caregiving is that 75%, or 3 out of 4 of critically ill patients, will require a caregiver or will be unable to make decisions for themselves. And that at some period, whether it's in the ICU or transfer or discharge out of the ICU into an institutional setting such as a skilled nursing facility or a long-term acute care facility, nearly all ICU patients who've had 3 days or more stay in the ICU will require a surrogate or a caregiver. What's interesting is that oftentimes when we interact with these patients and families, they're in systems of crisis, and they're looking for help. Oftentimes, assuming the caregiver role or the decision-making role is an extreme strain or burden on their psyche, that oftentimes they're dealing with recurrent episodes of hospital-acquired infections, a roller coaster of ups and downs of recovery, and then losses again, and then the anticipation of the eventual patient's death. Families are oftentimes reporting unmet needs from clinicians. Those things are communication, a perceived lack of emotional support, and a desire to be near that patient at all times. But these symptoms that these caregivers and family members exposed are related back to impairments into emotional regulatory processes, which oftentimes make it difficult for them to understand and process information. These impairments to emotion regulation and information processing can lead to impulsive decision-making, uncertainty about how to plan care accordingly, and the termination of self-management behaviors. My second objective, now that I've kind of painted the picture about why these caregivers are particularly at risk or vulnerable population, is really to understand the linkage between brain science and self-management. And when we look at our existing models of self-management, they are predominantly behavioral in nature and often do not address the basic biological processes underlying self-management, such as brain activity. Despite the fact that many of our proposed self-management processes are cognitive in nature, such as when we look at self-efficacy or motivation, decision-making, many of these things are cognitive mechanisms that have been minimally investigated to understand the underlying biological processes. With the advancements of technology, particularly functional magnetic resonance imaging or fMRIs, we now have new opportunities to identify the neurobiological mechanisms that underlie the acquisition of new information, how that information is processed, and how it's used to not only initiate but sustain self-management behaviors. Research in the area of cognitive processing has identified two broad cortical networks. The first is referred to as the task positive network, which is involved with using skills, knowledge, and self-monitoring for problem solving and goal-directed action. To me, that represents many of the behaviors of self-management. And the second dimension or cortical network is the default mode network, which focuses on emotion management, self-awareness, and relationships. And we've been able to detect the neural activity associated with these particular cortical networks using fMRI. Additionally, these two broad networks tend to be antagonistic, such that when one network is activated, the other is inhibited. Therefore, I, along with my multidisciplinary team of scientists, suspect that the activation or inhibition of these two cortical neural networks have important implications for self-management science, since an individual can only efficiently adopt one mode at a given time. As a result, the initiation and, more importantly, sustaining self-management behaviors is likely to be achieved when there is balance between these two cortical neural networks. Now, the figure on this slide comes from one of my collaborators, Dr. Anthony Jack. Dr. Jack is a neurocognitive scientist with a particular interest in imaging. And his work really lays the foundation for my team, which is being able to identify the underlying processes and brain activity associated with self-management activities. Now, this image is an image of an individual's brain. And this particular participant was exposed to one of Dr. Jack's coaching interventions. And as you can see, there's been some increase in the brain activity. And for those neurocognitive scientists in the room, that particular brain region of the ventral medial prefrontal cortex and its adjacent anterior cingulate showed some increased activity. Now, Dr. Jack and I have posited that these areas have been associated with motivation, a component of the default mode network. And that with this work, along with the emerging evidence in neuroscience, we're able to show that self-management interventions can influence the brain activity. And that leads me to a major concept of our current work, which is focused on decentering. Now, many of the folks in this room may not be aware of decentering. Decentering is a metacognitive task that enables individuals to appraise their thoughts and feelings as mental events with a healthy psychological distance or a detached perspective. Individuals who can effectively decenter their thoughts and their feelings can disrupt perceptive thinking or rumination and efficiently switch between the task positive and default mode networks. Now, for my family members of critically ill patients who experience heightened states of psychological distress, the activation of their default mode networks may impose antagonistic inhibition of their task positive network. The brain regions, again, responsible for problem solving and goal-directed action. Again, remember I alluded to that sort of conceptualizes self-management. Now, the inhibition of the task-positive network is likely to predispose these new caregivers to unregulated states of perceptive thinking, suppression of decentering mechanisms, ego depletion that results in premature termination of self-management behaviors. And then there's a growing body of empirical evidence that supports that mindful-based interventions can help individuals decenter, which is leading to our current work with developing a technology that will use decentering as a new biobehavioral target for self-management interventions. And so we hope to counter the potential detrimental effects of caregiving and dysregulation of the task-positive and default mode networks by evaluating a theoretically derived adaptive sensor-based intervention for caregiver self-management referred to as ASSIST. The ASSIST intervention has two theoretical components which hope to address these particular cortical networks by delivering a mindful-based meditation training as well as directive strategies to promote sleep, hygiene, and physical activity among new caregivers of ICU patients. We believe that the intervention will expose patients to real-time adaptive interventions. All participants will receive a daily dose of mindful-based meditation delivered by the Samsung SimBand, a new technology that's not even out for commercial use at this point, and receive directed self-management strategies focused on sleep hygiene and physical activity. The ASSIST intervention is innovative in that it will capture not only biophysical data, it will analyze the participants' data and deliver a mindful-based meditation training and health promotion strategies based on the participants' real-time state. It is our supposition that providing real-time, adaptive, and directive strategies will help these caregivers recognize strategies to address the task-positive and default mode networks, leading to the initiation and maintenance of self-management behaviors. All right. This slide represents it's really busy, but it's our study model. And this particular study model is a sub-project of an NINR-funded self-management center that looks at brain behavior connections. And one of the things that I want to highlight here is that we suppose or posit that decentering is a mediator in this particular model, and that the other component of my talk here was to focus on social context, and that in this model, the role of social context is also posited as a potential moderator. We feel that the acquisition of the caregiver role by family members of patients who have survived the ICU course is suspected to moderate their perceived beliefs of their self-management intervention, as well as we're also looking at factors such as caregiver role, environmental settings, cultural determinants, and social support, which we know are all important and vital components to self-management outcomes. So in preparation for this talk, I thought to myself, so supposing that this intervention works, this model is found to be appropriate and valid, where would I envision the future of self-management in 20 years from this point? I'd ask that hopefully in 20 years we have better understanding of the biological and neurobiological underpinnings of self-management. And secondly, I'd like, as an interventionist who's focused on e-health and mobile health, I'd like to see evidence-based e-health and mobile health technologies out there. And so that's where I would see the vision for self-management, is capitalizing on what we know to enhance learning, enhance the experience and sustainability of self-management behaviors, as well as using ubiquitous technologies. So lastly, in this presentation, I've tried to highlight the associations between neurobiology, personal strengths, and social contexts, and many of which have been minimally investigated in the literature. And hopefully, as we listen to and hear the discussion, hopefully on future self-management science, I encourage sort of further dialogue that asks provocative questions about how personal strengths and social contexts can be leveraged to enhance self-management performance. And this concludes my presentation. Thank you for your time.
Entertain discussion from your chair or from up there?
Either one, it doesn't matter. I can see the room better probably by standing up, so.
Okay. Does anyone have questions or comments for Ron? Jeff and David, our events management people, told me it is much easier for them to process to record if we go down one side of the room and then around. So, anyone? Well, I'm curious, could you go back to your model? That particularly intrigues me, and
I'll try to get it back up here for you. There we are.
Perfect. When the distal outcomes are your bio and neurological measures, correct?
Well, actually,
oh no, they're here in decentering.
As a component of a mediating process is neural processing, and in that particular concept, we have neural processing, which is being operationalized by brain activity using structural and functional MRIs. We're looking at the activation of the HPA or hypothalamic pituitary axis, as well as traditional measures of cognitive processing, such as self-efficacy, decision-making, motivation, as displayed here. In your vision from tomorrow through the next 20 years, I mean, some of these, well, let me back up. Some of the decentering and obviously the health status currently can be captured by personal technologies. Do you, within this 20-year Hickman-based future, which ones of, do you see a future in which more of these measures can be captured by personal technologies? Under the
or which ones do you, if you could add 1, 2, or 3 in a priority, which would, like, you know, you can't do an fMRI with your smartphone yet, but you might be able to. You laugh, but it might happen in our lifetimes. If you have the right smartphone and app, you can do. You could test saliva. You can currently people in treatment or drug court can do urine tests through their smartphones. So, which would you think would be most useful for live or personal testing through smartphones? In your vision, what do you think would give you the next big boost?
Wow. as a guy that's interested in decision making, I want to default there. But we know that self-efficacy has been a powerful factor in promoting self-management. So being able really to be able to sort of tease out some of the psychosocial mediators and be able to have a biological underpinning of them that can be captured by a sensor would be phenomenal. I know that there's work to be done in that area. I know that the NIH Precision Medicine Initiative is looking to capture some of this and triangulate some of this data so that we can have that. So I'd say self-efficacy, maybe motivation would be a secondary one for me as well. But when I see the Hickman future, what I'd see is a technology where we'll be able to use environmental cueing to raise awareness that maybe it's time to go to bed, or to promote self-management behaviors. Maybe you've been sedentary for a little while, so your Fitbit actually tells you a little bit to maybe stand or take a few steps. But that's the type of cueing or behavior that's out there, being able to capture this data and then be able to send cues to the individual to promote and sustain these behaviors.
Thanks, Ron. Any other? Yeah, Marvin?
So thank you very much. The question that keeps coming in my mind when we try to help people who either have significant psychosocial problems or maybe in the intensive care, deep in despair, is how do we really reach them to change behavior? And you have this nice little sensor that tells somebody you're having a problem right now, and then you have an intervention which gives people cues. And I'm really fascinated and interested in what you think about when is it that kind of more distant e-health technologies, simple advice, web-based, type messages versus that personal touch is really going to be required, and how do we decide? I haven't seen a lot of studies. I think there's a lot of studies going on right now, but that real, what does it really take to get people to change, and can, our hope that e-technologies that don't require a personal touch will work versus it's only going to work with a personal touch because the way we're wired.
Right. Well, I will say this, at least in my population of caregivers, I know 50% of the individuals want some electronic means to do it independently, and the other half wants interventions that are delivered in person because of the emotional component of it. And I don't think we'll ever completely escape or have an isolated e-health intervention completely because of, at least with some of the psychosocial concepts with coaching and self-efficacy that's needed. A face-to-face might be better, although I'm getting some really positive responses with the use of my avatar-based work that can simulate some of the coaching. But we don't know, and I'd like to be able to explore that. And I think with self-management science, I think being able to look at different modalities and seeing where to up-titrate. So for instance, some people might just need web-based. Some people might need a face-to-face coach, and some might want something a little bit more sophisticated to help them sustain their self-management behaviors. And so that's where at least my work is heading towards, is being able to understand for whom these types of e-health interventions truly work for. Thank you. I think the gentleman in the back.
If you're getting stressed, you could be connected to someone who's also kind of stressed at that moment. Having those peer interactions that are combined with these notifications to kind of create this social network and support from other people while you're having these personalized interventions.
That's correct. And so we're seeing an explosion of interventions that are using that type of synergy between e-health technology or platforms for social media combined with these e-health devices and platforms. I think there was a hand there.
Does your intervention, do you think it affects self-regulation? Because a wearable e-health device that cues you to do something, to some extent you could think of that philosophically as surrendering self-regulatory activity. You see what I'm saying?
Yes.
Something. So I'm trying to think about those two networks you were talking about, the Impede and
Mm-hmm.
the
Right.
right? So someone who's very stressed, they're a caregiver, they're very concerned about a family member in ICU or putting in
Mm-hmm.
Like, which of the networks is overwhelming the other at that time, typically?
So typically, you would say the default mode, because of the stress component of it, is overwhelming. It's the default mode network is used for emotion management primarily, and so the task positive mode or node, it typically helps with goal-orienting problem solving. So we want to find sort of a fine balance, the fine tuning of them. And your comment on sort of giving up self-regulatory processes is something to pay attention to. And maybe in this case, since these family members and caregivers are oftentimes looking for help or in such despair, it's okay. And that's where context, I think, comes into play. Yes, ma'am.
I think you partly answered my question with your comments. And in substance abuse, the therapists often use e-technology or technology to accompany the patient when they go away from the clinic. So I was thinking about how you see the person in the ICU or the family member in the ICU accessing this technology. I mean, do they just go home and download an app, or do they interact with a social worker or someone in the context of the care unit to help them with?
So that's a great question. So in my prior work, I've tried to liberate the need for a professional or clinician to deliver this. And so we provide tablets or PCs for these individuals or participants to use the devices. And we want the flexibility of having the participants use this when they need it the most, on demand. Yes, ma'am.
I understand that, but, I understand that. So my question is how the person, the caregiver, gets this. I mean, they are given this when their family member is in the ICU by someone associated with a hospital, or do they just on their own
Okay.
search it off the?
No. So for right now, with the particular project that we're talking about with the wearable sensor, research staff is providing the sensor and showing them how to access this program. So it's not available on the internet, web-based, for public use at this point in time. And no, we have not used clinicians to deliver it, but our research staff is actually giving them the devices and showing them how to access these resources. Did that answer the question?
Yes. I was thinking more about how this would work in the real world.
So in the real world, I hope that, yeah, the scalability of this is that as we think about the large scale, that this would be made publicly available, and that we try to be platform agnostic so it can go across platforms, web-based. It doesn't matter if you're an Apple or Android user, so that if clinicians could actually refer patients, family members to these devices where they could, or this program where they could access. So that's the scalability component of it. I think there were some questions in the back there.
I'm Karen Huss from NINR. My question is the same thing, having to do with sustainability, and how are you going to then transition this from like a step-down unit to the next stage of the environment that the individual and the caregiver will be moving to? Because we're hoping they're going to move out of the ICU unit into.
So with this one, we're really focused on caregiver self-management, and so it's hopefully can be used across context, regardless of in the ICU or beyond. These are I think, health promotion strategies that would benefit these caregivers and help them sustain not only their own health, but the health of the individuals that they're providing care. So the band will follow them or be with them as they cross these contexts.
I was thinking in terms of the care providers as they're moving from one stage of their care trajectory to the next, that they're also going to have to be built in otherwise, because they may need assistance with using this technology that they have.
So in the real world application, yes.
Self-management involves the healthcare team, not just the patient, the family. It's also the healthcare provider, the system, the community, et cetera. So I'd say more broadly. So I think if you start thinking about that now as you're moving your model along, I think you'll be well prepared.
Thank you very much, Dr. Huss.
One more question, Bill?
With some of these technologies, I certainly think that with university-based care systems and certainly the VA, we have seen a number of electronic mHealth and other devices to help both patients and families deal with chronic conditions, whether it is depression and PTSD-based psychological issues or dual diagnoses in that regard, wounded warriors who have serious conditions, either brain injuries or what are these, leg or extremity missing limbs. They are making great strides both in the hospital settings and in aftercare. I guess I should have invited someone from DoD or VA, but that next time. But I think we can look to both that and obviously a natural step for when it comes to dissemination and implementation projects would be for Dr. Hickman and others to roll out these interventions through their own healthcare facilities or their research hospital partners.
Any other questions?
Please welcome Dr. Drenna Waldrop-Valverde. I'll let her tell you a little bit about herself, and then she can take it from there. Thank you.
Hi, good morning. Can you all hear me okay? Okay, perfect. Sorry for running a little late, one of those days. So yes, my name is Drenna Waldrop-Valverde. Please just call me Drenna. It's, I'm sure, the longest name on the program. I'm from Emory University in Atlanta, and I've been fortunate enough for the past 3 years, going into 4 years, to direct the Center for Neurocognitive Studies at the Nell Hodgson Woodruff School of Nursing. The center is funded by the NINR, so I have a list of thank yous at the end, but I want to start with a big thank you to the NINR for this project. So what I'll be talking about for a little while this morning, what I hope to stimulate some thoughts on, is, and it's a great segue from Dr. Hickman's talk, where I'll be talking more about chronic illness and kind of dealing with the management of chronic illness over time. And what are some of the core basic behavioral sets of skills that we might need to be able to take care of ourselves and take care of our loved ones. And why is it that some of those very skills that are so important for self-management are the very skills that can be impacted by the chronic illnesses that we are trying to self-manage? So it's kind of a circular process. So I'll talk a little bit about the center, what it's about, and some of the pilot projects that we have been fortunate enough to be working on with the center. Some of my own work that's a little separate from the center but still related, and then have some time for questions, hopefully. So when we think about operationalizing self-management, the framework that I've been working from, and again, I certainly want to not discount the myriad of factors that can influence self-management, but again, I'm sort of focusing in on a core set of behavioral skills. You can think about them as cognitive subsets of skills that are really needed to manage day-to-day behaviors. And if you look at some of the work by some of the most well-known and classic folks who do self-management theory, Dr. Lorig, some of the five core self-management skills that she talks about are problem solving, decision making, which were already brought up, utilizing resources, forming a healthcare provider relationship, and then taking action. So some of the areas that I will be focusing are really those first two bullets there, problem solving and decision making will be some of the work that I'll be talking about. So even though a lot of chronic illnesses that we think about that affect so many Americans and people around the world don't necessarily directly affect the brain, they don't have to think about a stroke, for instance, but so many of the chronic systemic conditions that we deal with do impact the brain. We don't often think about that, so that's sort of a takeaway message I hope will come from today. So just a little background, chronic illness, as you know, is a big problem in the U.S. 7 out of 10 deaths are caused by a chronic illness, and nearly half of Americans have a chronic condition. 1/4 of those have a functional limitation resulting from that chronic illness. And the number of Americans over 65, that group is more likely to have chronic conditions, will double by 2030. So some of the conditions that I mentioned that I'll talk about that have an impact on cognitive function or it can result in some cognitive impairment are those that don't always directly affect the brain. So cardiovascular disease is, I think, one of the areas where we've seen a lot of research and a lot of interest in this area in the relatively recent past. Diabetes as well. Kidney disease is certainly an area that can affect cognitive function. And my own work has been in HIV/AIDS, and we're still finding an impact on cognitive function, even among those who are virologically controlled. Cognitive function, chronic illness, is also associated with greater emotional distress, and I'll go ahead and say that most of the work that we're doing is associated with cognition, but you certainly cannot rule out the impact of affective issues and how they interact with one another. So that can be an area that I think definitely needs more work. And those experiencing chronic illnesses certainly have a greater prevalence of affective issues as well. So some of the things that can that can result from cognitive impairment, which I've listed here as NCI, is reduced. So you think about having a reduced capacity to carry out the behaviors. That can sort of be the bucket of the cognitive dysfunction, and then the affective issues can result in reduced motivation. Not that they are separate issues, of course, but it's sort of a way of conceptualizing. Of course, affective distress can also impact neuroendocrine cascades, immune function. That's not a purpose of this talk, but again, to highlight that these skill sets and these issues are not working in isolation. And as I mentioned, the cognitive and affective issues can certainly compound one another. The nature of cognitive deficits and how they impact self-care can certainly vary by the type of illness that you have, the severity of that illness over time, the dynamic nature of many illnesses as symptoms wax and wane. The presence of comorbidities and multimorbidities is going to be a huge issue, and already a huge issue, as the U.S. population continues to age. And of course, environmental contributors as well. And that's not just the environment as far as toxins and exposures, but also resources and access to care and things such as that. And many of our healthcare providers are not, again, thinking about the chronic illnesses in terms of cognitive and affective issues unless the illness is thought to directly impact the brain. So here's just a few examples of some of the mechanisms by which the brain can be impacted by in the experience of these chronic illnesses. For cardiovascular disease, you've got decreased blood perfusion, you've got amyloid deposits in the brain. Atherosclerosis can certainly impact the blood flow and then the brain function. In a congestive heart failure, which is a really severe form, of course, of cardiovascular disease, individuals have shown deficits in verbal learning and working memory, mental flexibility, sort of being able to hold pieces of information in your head for a short amount of time and manipulate it. Like we used to have to look at a phone number in the phone book, remember it, hold it in your mind, and then go punch it into the phone. I'm dating myself, I realize, but some of us still do that. And hypertension, which is incredibly common. So many people suffer from hypertension and they don't even know it. And hypertension is being more and more recognized as being associated with some cognitive deficits in areas that we consider more higher order processing speed, and things that can also impact memory impairment if you have issues with processing speed and attention as well. So some of our even more mild chronic illnesses can be associated with some cognitive dysfunction as well. In my neck of the woods in working with HIV/AIDS, some of the cognitive issues that we see, again, in the long-term infected, really well virologically controlled populations, we'll see poor concentration and memory, poor concentration and attention, problems with short-term memory, problem-solving issues, calculation abilities, not being able to do math problems, and not from the standpoint of not having learned math in school, but from the standpoint of being able to process that information. Problems planning ahead, learning new things. We certainly see in HIV some psychomotor kinds of symptoms. We also see these behavioral symptoms, agitation and personality changes, and changes in mood as well. So a little about affect and mood as well. Some of the same conditions that are associated with a greater rate of some cognitive dysfunction are certainly associated with issues with low mood and problems with affect. Depression, of course, is the most common of these, and it has been the most highly studied among nearly all of these conditions, and the presence of the chronic illness is strongly associated with the presence of depression as well. When you put depression in the mix, you're more likely to have more issues with your illness, self-management, functional disability, and has been associated with a greater rate of death as well. So the framework for the Center for Neurocognitive Studies is this. I'm sorry, it's a little bit small. And as I mentioned before, our thought process is very circular in that all of these issues affect one another and can exacerbate one another. Flip it around, I can think positively, these issues can also benefit the various symptoms and the self-management behaviors as well. So some of the areas that we are looking at specifically that show how cognitive deficits can exacerbate illnesses are, again, with self-management of illness, adherence to medications. That's been some of the work I've done in HIV, but also, of course, adherence to diet and exercise. And then in regards to managing symptoms, the cognitive deficits may delay someone's or a caregiver's ability to act upon those symptoms. And there really has not been, to my knowledge, a large body of work looking at the impact of cognitive impairment on self-management in chronic medical conditions. We tend, again, to think of the brain as sort of up here and separate from everything else, but it's really not. So back to HIV and some of the work that I've done. The work that has been done in this area has really consistently shown these areas to be impacted by the HIV condition when the individual's been living with the disease for quite some time, and even when it's well controlled. So issues of prospective memory, that's remembering to remember. Executive functioning is a large umbrella term, and it really encompasses things such as being able to plan ahead, to organize, to multitask, and it's getting into all the details of it, you have to have really good attention skills. That's kind of core, and then that builds on your memory skills, and that builds on your planning skills and things like that. So it's a large umbrella term, and we find a lot of issues in executive function in HIV, and as well as working memory, which is sometimes subsumed under executive functioning. And then again, as the HIV population ages, you have the issues of aging, which are also added on top of the issues of the HIV virus itself, and so it's going to be we expect an even larger issue in that population. And then again, back to affect and mood. Depression is also linked to poor self-management. These things go hand in hand. It's often very difficult to tease out, is it depression, is it cognitive dysfunction, because they often coexist so much. Depression itself, major depressive disorders associated with issues with depression, with attention, executive function, sound familiar, visual-spatial memory, and it can certainly impact learning through through the deficits in attention. And what are some of the elements of depression that affect self-management? That's I'm working with some postdocs now to look at that in terms of retention in HIV care, and we'll have to wait on those results. We don't know yet. And then, as I mentioned earlier, multimorbidity, so chronic illness in the context of people having multiple chronic illnesses, and particularly in the aging population. Understanding how these chronic conditions affect the brain and brain health and brain and behavior relationships, I think, is going to be really, really important in the not so far off future. Okay, just things you probably already know about folks with multimorbidities, how they tend to have more and more problems based not only on the conditions themselves, but on the multiple medications that they're taking as well, which is something else that we need to consider. So the Center for Neurocognitive Studies is trying to make a dent in some of these issues. We have, we had 3 pilots. One person moved somewhere else. We're in transition. So we have two pilots that I'll mention today. The first pilot has finished collecting data, and she is analyzing her findings now. And she's looking at that population of individuals who have hypertension, who are untreated, who have sort of subclinical and low clinical levels of hypertension, and what is the relationship of their cognitive skills, their affect, and sleep, which I believe we'll be hearing about in a little while as well. All of these issues are very common in the population, and how do they relate to one another? What are some of the biomarkers that may be associated with these relationships? And they're really in the pilot phase in trying to describe the problem, sort of characterize what's going on in the population to be able to map some of the key issues and some of the key mediators and moderators of these relationships. Our second pilot study is looking at an exercise and a cognitive retraining intervention, and she's working with individuals with heart failure. And we're looking at a 3-arm intervention. So she's doing, Dr. Becky Gary is the PI, and she's doing the an exercise plus cognitive retraining. This is a computerized cognitive retraining. If you've seen the commercials for, I do this work because I have a terrible memory. Luminosity, that's the one. So we're not using luminosity, but it's something like that. So the premise is that with the benefits of exercise in brain health and cardiovascular function and what have you, hopefully that may sort of prime the brain to be able to better utilize the cognitive retraining. So we have a control arm, an exercise-only arm, and an exercise and cognitive retraining arm. Interestingly enough, just as a little aside, we've actually had more grumbling about from the participants about the cognitive retraining than the exercise. So I thought that was kind of interesting. So we've worked with some incentives to get folks to do the computer cognitive training. And she is in her final 3 to 4 months of data collection for this as well. So hopefully we'll have some interesting findings out for you soon about this one. And I have a question mark here. We put in a supplement for the center that is related to this exercise pilot that I just mentioned, where we'll be looking at our participants in terms of some brain imaging as well. We will be looking at DTI, resting state functional MRIs, and so this goes back to some of the things Dr. Hickman was talking about. So hopefully, I have not heard yet, that will work out for us, and we'll be able to look at some of these questions at a very basic level through some of the brain imaging work. Okay, so I'll talk a little bit, how am I doing on time? I'll talk a little bit briefly about some of the work that I've done in the past, asking some of these questions about what are some of the basic skill sets that are impacted in the chronic illness that I'm interested in, which happens to be HIV, and how does it impact the individual self-management. So this paper was looking at HIV-positive injecting drug users, which, if you can imagine, have a number of issues associated with cognitive functioning, not only from HIV, but also from drug use. And these are some of the, we gave a multitude of tests. We had a comprehensive neurocognitive battery and a number of other things as well, but without getting into those details, what we did was we took the individual scores from these cognitive tests. Are you all familiar with neurocognitive tests? I didn't put a lot of slides in on that. So instead of asking someone self-report, are you having trouble remembering? Do you often lose your keys? One of my personal favorites. Do you have trouble manipulating keys into locks and things? Instead of asking someone their opinion of how they do these things, we have performance-based tests that are often timed. They require, paraphernalia and what have you. So if someone carries out a task, and based on hopefully good norms, based on their age, their gender, their years of education, less so their race, ethnicity, but that's getting better. We compare their performance to others like them, and we would expect them to fall within a similar range of performance unless there's an issue in that particular cognitive area. So that's in a nutshell kind of what the cognitive tests do. So what we did was give a number of tests, and then we combined the test scores into 3 areas of executive function. We looked at memory, both learning and delayed recall, and then also psychomotor speed, because that's a particularly big issue with HIV. And what these next 3 slides tell you is that controlling for these other issues that the individuals reported, when we looked at the memory domain, and then we looked at the executive domain, you see the bottom the next to the last row changes. And then the psychomotor domain, if you look at the confidence intervals, you'll see that the psychomotor domain was significantly associated with self-reported adherence, and that was our medication adherence was our outcome for this study. Now, in HIV, psychomotor performance is more than just manipulating something with your hands. It's sort of reflective of overall disease state and has a lot to do with processing speed and being able to think through multiple steps. This was a multi-step psychomotor test that required a number of sequences of activities before they got the score. And then in this study, we did something similar where we looked at cognitive impairment. We also accounted for, in this population, we accounted for reading level and sort of educational attainment. In that way, we found that a lot of the participants in the study would report taking their medications like they were supposed to, but then when you compared what they said they were doing and when they thought they were doing it correctly with the actual prescription instructions, they oftentimes did not match. Here we go. And so what we did for this study is we combined the cognitive performance. We divided people into impaired and non-impaired cognitive performance, sort of an overall global measure, with high literacy and low literacy. And we did that with the wide range achievement test to be able to look at their reading. Yes?
Do you mean health literacy or overall?
In this case, it was just overall literacy, but I do a lot of work in health literacy as well. But this was just a reading test, not necessarily for health-related words. And you'll see here that of the bottom line, for those individuals that have both low literacy and low cognitive performance, so they had cognitive impairment 2 standard deviations below the mean, they were 9 times more likely to be non-adherent to their medications. And health literacy was the next area of work where I have done some work in cognition and self-management. And I think this slide was supposed to have been removed, but there it is. It's a little bit about our study. And so medication management capacity was the outcome for this study. And that's a little bit different from just adherence. Are you taking your medicine like you're supposed to? Have you missed a pill in the last week? Have you missed a pill in the last 30 days? Capacity is more accuracy. We used a simulated regimen, so 5 pills. Each pill bottle had its own label. Each bottle has to have a certain number of medications in it, and the individuals go through a series of tasks. They answer questions about a medication insert and when to go to the doctor, what some of the symptoms can be, what do you do if you have diarrhea, things like that. And then they do things like counting out the number of pills they would need to take each day. You're going to be taking a trip in 5 days. Look at medication age. Are you going to need to get a refill before you go? So a lot of real-world sort of problem-solving behaviors with this measure. It's called the Medication Management Test Revised. I'd be happy to get the reference for you. Just quickly, what we found in this study was that if you look at, I have a pointer here. What does it do? Oh, there we go. So when you just put these demographic variables in the model at first, just about everything comes out to be significantly related to medication management capacity. But when you put in these cognitive function variables, you put in executive measures, verbal memory measures, planning measures, and the psychomotor, you find that the executive skill set and the planning skill set are the ones that are actually associated with medication management capacity, being able to carry out the skills you would need to manage your medications, and then the demographic variables were no longer significant. And then quickly, the next study looked at a different self-management behavior, which was retention in HIV care. So you can't get your medications and adhere to them if you don't go to your provider and get regular care and get the prescriptions. So we had a baseline interview. We followed people for 28 weeks and then did a follow-up interview, and we did medical record abstractions over that time to get the number of scheduled appointments that individuals attended. That was our outcome. And then quickly, the findings showed that when we looked at a direct relationship between our cognitive variable, which is MPZ-8, it's a combination of 8 different neuropsychological test scores. When you looked at directly with retention and care, there was no relationship. We thought if you have cognitive impairment, you may forget to go to your appointments. You may get disorganized. You may have problems with prospective memory, what have you. So we expected to see a relationship there. We didn't see their relationship there. What we found instead was that for those individuals who had cognitive impairment but had good social support, they were more likely to attend their scheduled HIV medical appointments as just like those who did not have cognitive impairments. We found a moderating effect there. And this is just a graph depicting that moderating effect. So sometimes we have to think a little bit outside of our, of course, direct question and think about, given the fact that self-management behaviors are so complex and the cognitive pieces are just one of many important variables that are needed to take care of our chronic illnesses, we can think about some ways that other experiences that may be impacting the relationship and things that people are naturally doing in the real world that we can build upon for interventions. So I'd like to propose, and so for the takeaway message, 2 takeaway messages, maybe 3, but 2 for sure. The first is that even though you don't have a brain disease, your chronic illness is probably affecting your brain. It may not manifest itself in the inability to self-manage. It may not show up on cognitive testing. It may not show up on brain imaging, but it's in there. It's affecting your brain. And we need to think about how that brain health impacts self-management, and whether it's from the standpoint of the caregiving and their ability to understand what the loved one or the caregivee is dealing with, and the care recipient themselves. So cognitive skills, I think, are really core. I kind of think about it as an onion, that even if a lot of these other key pieces are in place, they may be more or less effective depending on those core sets of cognitive skills that are needed to make those decisions, to problem solve, to be motivated to do things on a day-to-day basis. So when you think about having knowledge of your condition, adapting it to current situations, those all require memory, right? We think about making plans and organizing our schedule. I'm trying to get my parents to come over and visit. Well, my dad's got all of these doctor visits. They're trying to find when they can come between soccer games and my travel and his visits. Being able to do all that sort of thing, that requires brain health. It requires memory and planning and organizing. And I think sometimes we forget that just because we have a brain and we use it, that it's part of the picture, right? And then, of course, avoiding distractions, maintaining concentration, being able to do more than one thing at a time. Some people do great with self-management until something in the routine changes and it completely throws them off. And being able to understand what an individual's strengths are, what do you have to work with, what are the areas that can be, problems for them and barriers, I think can be really important in understanding and tailoring some interventions to work with individuals who have chronic illness. And then, of course, once you have it figured out, it changes because the chronic illness changes over time or they get something new. So this is my thank you slide. These are the grant support I've had over the years to help with the center, and then the work that I've done in HIV as well. And that's all. Thank you very much.
So much to think about, and so many accomplishments, Drenna. Thank you so much. Do you want to, Michael? Please come join us. And would you like to talk from there or from the table? Okay.
Here's fine.
Linda Larkey.
So what are the tests, the neurocognitive tests that you use to look at cognitive performance as opposed to reported?
Right. And I'm not knocking reported at all. It certainly has its place, and we use both. But where that can get sticky, and I'm not quite answering your question yet, but where that can get sticky is if someone is feeling, having trouble remembering and concentrating, but it's really because of depression, then those poor concentration and memory skill impairments more than likely would not show up on these kinds of objective testing. So anytime you use self-report, you need to keep in mind that depression can certainly influence how someone sees their abilities. And it's not that they aren't slowed a little bit or they aren't having a little trouble concentrating. It's just not to the point where they would get an impaired score on one of our tests. So something to keep in mind. Mm-hmm. Right. We just had a paper accepted in AIDS patient care and STDs looking at that. So no, that wasn't that one. It was another one. Sorry. My son's birthday was yesterday. I flew up really, really late and I'm tired. So the tests that we use, there are a host of tests out there. There are a lot of tests. So if you have a specific question in mind, it's really best to consult with someone who can help you isolate a very a very specific test. Things like the mini mental status are very global, and so they have one or two questions that tap into many different domains, but they're really designed to detect people with dementia. So a lot of what I was talking about today is I didn't go to my dementia talk. It's not so much about dementia, not that that's not important, but what we're talking about here is really sort of low grade, mild to maybe moderate cognitive dysfunction, where someone doesn't need to be institutionalized. They can still, manage to take care of themselves for the most part day to day, but are they really doing it well? Are they doing it in such a way that they are optimizing their care and minimizing their symptoms and exacerbating illness? So there are really a lot of tests out there, lots and lots of tests. So, well, I mean, I probably gave 30 different tests across my different studies. It's really a lot. We can talk more. Hi.
Thank you for a wonderful talk, Drenna. My question speaks to your model. You had a first stage of your regression model with just demographic factors.
Mm-hmm.
The second stage included the demographic factors and the neurocognitive
Yes.
test results, and the demographic factors were no longer significant.
Mm-hmm.
The neurocognitive results predicted your outcomes.
Right.
My question speaks to you had nothing involving education in the demographic
Right.
model, and education in your population. You're going to have some people who left high school, people who finished high school,
Right.
maybe some people with post-diploma education, or maybe even associate's degrees.
Mm-hmm.
So you're going to have some variability in education, and that would probably explain some variability in your neurocognitive test results as well. Did you consider putting in an education variable of some sort in your first model?
We didn't, because the cognitive measures, the normative data is adjusted for education. So we did not use the raw scores. So let's say one score may be the number of correct words that someone remembers. Another score may be how quickly they complete a task. So number correct, the more the better. Time to complete, a higher number would be poorer performance. So we convert the raw scores to standard scores, and those are based on a number of demographic factors, including education. And so our thought, and I would be open, of course, to other opinions, that our thought was that if you adjust for education in the model, and you've also adjusted your cognitive scores for education, it's a little maybe over controlling. So that was our rationale. Good question. Thank you.
Any other questions?
I think you'll see a really better flow than I ever predicted from Ron to Drenna, and now Arizona State's Frank Inferna.
Thank you so much. And yeah, my name is Frank Inferna. I'm an assistant professor in the Department of Psychology at Arizona State University. And today my talk is going to broadly be focusing on biomarkers and the measurement of self-management. And I'll be weaving in, first of all, talking about my own program of research and how it incorporates biomarkers into it, and then focus more broadly on biomarkers in general. And before I begin, I'd like to acknowledge and thank the funding agencies, National Institute on Aging, who's been supporting the project that I'll be discussing primarily today, and also my colleagues at ASU for their insightful comments and feedback on this project and related projects. So here's my brief outline in terms of what I'll be discussing today. So first, be discussing my program of research looking at self-management in the context of childhood abuse and focusing on psychosocial consequences, but also intervention implications and how we're in the field currently on an intervention aimed at improving one's capacity for self-management in the context of childhood abuse, and then focus more broadly on biomarkers and the measurement of self-management with a focus on the importance of the time scale and also in relation to the chronic illness. So my background is in lifespan developmental psychology, so I'm interested in development or conceptualizing development as a lifelong cumulative process with early life experiences, both positive and negative, having substantial implications for one's development into adulthood and old age. And when thinking about childhood abuse in the form of emotional, physical, or sexual abuse can have enormous ramifications for development into not only in childhood and adolescence, but into midlife and old age. And so population estimates of childhood abuse are comparable to those of leading causes of mortality in the United States and chronic conditions, with, depending on the survey or that you look at, around 20% of the population has experienced some form of childhood abuse before the age of 18. And this is not something that just ends in childhood and adolescence, but has the capacity to follow individuals throughout the course of their life. With colleagues at the Mayo Clinic, it's associated with ASU, we have been beginning discussions on how individuals who are going towards major transplants, such as lung and kidney and liver transplants, how the case of childhood abuse continues to show up in terms of influencing their day-to-day decisions and their lifetime throughout the course of their life. So that begs the question, so where's the role of self-management in all of this? So there are many definitions throughout the literature in terms of what is self-management. And in the context of childhood abuse, we broadly define self-management as one's ability to manage the psychosocial consequences and daily living inherent with child abuse. And so it's two parts. So that's the first part. And the second part is involving a multidimensional approach of combining biological, psychological, and social intervention techniques with a goal of maximizing self-regulatory processes. So next I'll be discussing what are the psychosocial consequences of child abuse, and then I'll set up on discussing the intervention that we're currently in the field on. So the implications or the effects of childhood abuse are wide-ranging, leading to increased utilization of healthcare and societal resources. Individuals are at increased risk for lifetime substance abuse problems, alcohol and tobacco, and also individuals are more likely to report somatic and psychological symptoms such as depressive symptoms and also chronic pain. And furthermore, individuals who report high levels of childhood abuse have increased risk for early disease onset and declines in physical health. And so what are some of the possible mechanisms that may be driving this association as a way to inform interventions to improve individuals' lives and reverse this relationship? So various mechanisms have been considered throughout the literature. So for one, looking at biological factors such as inflammation. Previous research has shown that individuals reporting higher levels of child abuse, they're more likely to show elevated levels of inflammation across various markers such as CRP, fibrinogen, and also IL-6. This has been shown in across life course. The second possible mechanism, and one that my research team were most interested in, is looking at social relationships. In our own research and our samples, we found that childhood abuse is associated with lower levels of family support, so having fewer individuals to confide in or less ability to go to individuals in terms of having, retaining, and forming positive ties. But also childhood abuse is associated with higher levels or increased levels of family strain, so relationships characterized by more strain and arguments. And lastly, we found that childhood abuse is associated with individual social emotional regulation capacities, with social emotional regulation being defined as one's ability to effectively regulate their daily emotions in relation to specific stimuli. So we found in a daily diary study where participants were given a tablet for 30 consecutive days and were asked to report on their daily well-being and also their positive and negative events, that individuals reporting higher levels of childhood trauma were more likely to report lower daily well-being, but also a stronger decline in positive affect on days when they reported negative events. So this could have been an argument with their family or friend, or a stressful day at work, or in the context of health and other domains. However, we also observed that individuals reporting higher levels of childhood abuse were more emotionally reactive to daily positive events. So they were more likely to show a stronger increase in positive affect on days when they experience a positive event, which is could be a meaningful relationship, or conversation with a family member, or having a good day at work. So this suggests that individuals are more responsive to their social context in terms of their positive and negative daily events, which could provide some insights into intervention implications. So coming back to our broad definition of self-management in the context of childhood abuse, up to this point, I've focused mostly on what are the consequences and possible mechanisms underlying this relationship. And next, I'd like to focus on the second component in terms of intervention application. So the sobering reality of the prevalence and consequences of child abuse highlight the need for interventions aimed at reversing its effects. So then what are ways that we can help individuals who have experienced childhood abuse to better manage these psychosocial consequences and also daily living? So this is the project that we're currently in the field on, and it's graciously supported by the National Institutes on Aging. And so here's our conceptual model, and that what I've been focusing on right now up to this point is this left half side. So looking at how it is that childhood abuse is associated with mental and physical health, and the role that social relationships play in this association. What I next like to talk about is this next part in terms of looking at this. So this is on a sample of individuals in midlife, ages 45 to 70, and really the focus on our social intelligence intervention, which is aimed at improving one's social relationship quality, so one's ability to retain and form new social ties, and how this can have a subsequent effect on improving mental and physical health. So our approach is multimodal. So we have our pre-test, post-test, and 3 and 6 month follow-ups where individuals are given self-report questionnaires across a wide range of items. We also collect saliva samples from participants at each of these 4 assessments that will eventually be analyzed for various biomarkers that I'll get into more detail later. And then also we have participants at the pre and the post-test are completing daily diaries for 2 consecutive weeks, so we can get at one's daily well-being and also their emotional reactivity to daily positive and negative events. And also a subset will be completing qualitative interviews, both the individual going through involved in the intervention and also their confidants or their partners, so we can better examine various communication processes may be influencing changes that we may be observing. So getting a more in-depth examination of what's happening. So why social intelligence training? So for one, empirically, we've observed that social relationships mediate the association between childhood abuse and health. But we view or hypothesize that social relationships or improvements in social relationships may be an initiator or driver of improving one's capacity to navigate their social world through improving social relationship quality that are characterized by less conflict, but also increasing emotional support. So for example, as a means to reduce emotional reactivity to daily stressors through increasing one's capability for the rapid restoration of social well-being with downstream health effects. So the social intelligence training is comprised of 4 core social cognitive principles. So the humanization of social relations, so considering viewing individuals not as objects, but as individuals and human beings, reducing automatic thoughts and the routinization of behaviors toward ourselves and others. So these automatic processes that may be occurring in terms of how we group or looking at norms of individuals, trying to reduce these thoughts, these unconscious processes, considering that each individual is unique, and also that socially intelligent behavior is a choice. So the intervention is delivered online. It's comprised of 42 10 to 15 minute videos, and this is through the Social Intelligence Institute. And so here is the website for the Social Intelligence Institute that provides way more detail that I can give in this talk about the intervention and what it's comprised of. And just ignore what time this screenshot was. It is Phoenix time, so it was 6:45 this morning, not 4 o'clock. I did get some sleep. But this can give a lot of details in terms of the different modules and the background of how we've developed this. And this is through my colleagues Alex Zatra and Eva Zatra, who've really spearheaded this component. So the 4 metacognitive principles are organized around 7 thematic modules. So within each of these modules, there are 6 sessions that individuals go through. And the idea is we want our participants to go through this over the course of, say, 6 to 8 weeks. Some people have gone through it through 2 weeks. We told them not to, but you can't stop people from doing what they want to do sometimes. So these 7 modules are focused on neuroplasticity, so the rewiring of the brain, or the capacity for us to rewire our brain, and how we view the world, our unconscious and unconscious processes. So whether or not when we view individuals, do we group them or stereotype them just based on their gender or their skin tone? Empathy, perspective taking, so are we able to effectively gauge other individuals' feelings and their thoughts and what they're going through? In-group, out-group biases, so this focuses on more us versus them mentality. Another module focuses on face-to-face and online communications with the advent of technologies, Twitter, Facebook, any other way to communicate online as opposed to face-to-face communications. This highlights the advantages of sitting down and having a meaningful face-to-face conversation with individuals. The 6th module focuses on social schema formation from past experiences. So how is it that our past experiences, not only in adulthood, but also in childhood and adolescence, could have continued influence on our social relationship quality and the formation of social relationships in adulthood and old age. And the choice of social intelligence is to relate. So this is the breakdown of so we are recruiting participants from an existing data set. So in 2009, colleagues from ASU collected data on 800 participants from the Phoenix metropolitan area who are in midlife, and based on that sample, 557 indicated that they're interested in future research studies. And then from that, we are determining their level of early life adversity. So childhood abuse is our key moderating variable in this study. And then from that, we'll have 100 individuals who indicated moderate to high levels of childhood abuse, and 100 in the low group, and then we'll divide them 100 into intervention and 100 into the control group. And so we are currently in the field, so hopefully in the future, you'll see some research coming out from this study. And so incorporating, where do biomarkers play into this? Within this study, we're focusing on 2 in particular, so DHEAS, which is a marker that proxy for helps in recovery from stressors by mitigating the effects of inflammation and oxidative stress. and also interleukin-6 or IL-6, which is released by immune cells to promote inflammatory response. And so these markers, we're assessing them at 4 time points, pre and post-test, and in a 3 and 6 month follow-ups. These are markers that change over a longer time scale and have been shown to be reliable and modifiable through previous interventions, through the work of Alexandra and colleagues, and have shown improvements or declines in IL-6 over a period of 3 months, and also increases in DHEAS, where higher levels are better or promote better functioning. So at this point, I've focused primarily on looking at self-management in the context of childhood abuse and within the context of my research program. And next, I'd like to focus more on biomarkers and to measure self-management, but more broadly, how they can incorporate into different research designs, and really emphasize the importance of the time scale of interest, or how is change really being characterized within the study can really have important implications for the marker that you're most interested in. Because development occurs across multiple levels or time scales, so seconds, minutes, hours, days, weeks, months, years, decades. So it's numerous ways or time scales that change occurs, and it's either more so looking at short or long-term processes of change. And when focusing on short-term processes of change, a lot of literature has been focusing on or looking at physiological reactivity to daily and also lab-based stressors, with an emphasis on the HPA and the SAM axis. And so this is so 2 markers that have been heavily studied are looking at cortisol and alpha amylase that follow this diurnal pattern with cortisol, the typical awakening response within 45 minutes, and then a slight steady decline over the course of the day, whereas alpha amylase shows an opposite pattern. And in terms of looking at physiological reactivity to daily and lab-based stressors, research within the context of childhood abuse has shown that in the lab-based, during the course of a lab-based stressor, which occurs through this time interval here, we see that individuals reporting higher levels of childhood abuse show a increased response to cortisol, to ACTH, but also increased heart rate. So they're more influence or more physiological reactive to these lab-based stressors. At least this is research from Hyman colleagues focusing on adolescents. However, when research has also looked at examining the influence of lab-based stressors on adults and looking at childhood abuse as a key moderator, and this research has shown a more blunted or less increase in cortisol as a function of lab-based stressors. So thinking about more developmentally over the course of time, the chronicity of childhood abuse and continued exposure to stressors may have subsequent influence on one's physiological reactivity. So moving on beyond just looking at physiological reactivity to lab-based stressors, but I'd like to focus in on research from Steve Zarrett and colleagues looking at caregivers of individuals with dementia, where they've been collecting data on caregivers for 8 consecutive days, so doing daily diaries, but also assessing their taking saliva multiple times throughout the course of the day to examine how it is that the utilization of adult daycare services can influence physiological functioning across the course of the day. And they found that individuals who, during non-adult day service days, individuals in the low CAR group and the medium cortisol awakening response group show more of a blunted response or blunted increase in cortisol at the beginning of the day. However, on days when they use adult daycare services, they showed this typical increase in the cortisol awakening response. So showing that depending on one's what's happening throughout the course of the day, and showing that these markers are flexible, or in terms are sensitive to changes that are occurring throughout the course of the day. And they also found that DHEAS was higher on days following adult day services utilization, and that it was in unison or was associated with higher levels in positive affects. So the black line is DHEAS, and then the red line is positive affects. So on days when DHEAS increased, there were subsequent increases or a covariation with positive affect. Next, focusing on markers or examining improvements in key markers of physiological functioning over longer time scales. So the previous studies focused more on looking at minutes and hours and the daily schedule. There's also research showing that cognitive behavioral stress management can lead to improvements in the cortisol DHEAS ratio over the course of 3 months. So thinking about development or changes over a longer time scale. And similarly, research looking at Tai Chi was associated with reduced systolic blood pressure and cortisol levels over the course of 3 months. Okay, so now to kind of bring it all back, and so focus of my talk was, in the first part, focusing on self-management in the context of childhood abuse and looking at the psychosocial consequences, but also looking at intervention implications and how can we reverse this cause-effect relationship with an emphasis on one's social relationships. And also, second half, discussing more so biomarkers in the measurement of self-management, and really, I think, in terms of moving forward, the special importance of one's time scale of interest and what is the marker that's best suited for the chronic condition or chronic illness that one is interested in. And physiological markers are malleable, or they do have the capacity to change, and just important to really think deeply about how it is that it can be best included in one's research program. And thank you. Yeah. Hi.
Glad.
Yeah, glad to meet you.
We're both from ASU, and we've never met each other, so we had a phone conversation a week and a half ago. So glad to meet you. I'm intrigued with this relationship around what happens later in life with childhood trauma and how social relationships may mediate that to some degree. And then later, when you were talking about things in the social intelligence training, you mentioned something about humanizing social interactions. I'm struck with the power of that phrase and what that's loaded with. I mean, like, how are social interactions not human? It made me go back to think about it, and then I get curious if some of the thinking behind this deals with attachment disorder issues. I have a son who was adopted when he was 2.5, and he'd already been through a lot.
Right.
And was attachment disorder. And when you describe some of these things that are intervened upon, they fit very well with what he has needed in order to humanize his interactions. So I get curious if that has informed any of the thinking around some of the choices
It's
made.
certainly informed our thinking and how the intervention, it's a combination of more social cognitive principles and also behavioral tasks. And so at the end of some of the modules, so for example, one of them is your task is to go out and just talk to a stranger or start up a conversation with a stranger as a way to have individuals actively engage in their social world. For some of the undergrads who were looked at who were part of the program, they took that to interact with pretty girls on the light rail at ASU. But more seriously, though, this is Thank you for the delayed response. Yeah.
This is humanizing? No.
But more seriously, I mean, thinking about attachment theory, and I think looking at how it is, yeah, and we get into that into the program in terms of looking at our past experiences and how we can kind of reshape our thinking or putting them into context to improve our current state of social relationship quality. And yeah, I think that's an important component and something that, yeah, we plan to look at once we have more data and we're able to test these sorts of questions. Thank you.
So that people on the phone or on the website can hear us, we need to speak into the microphones. And apparently, I don't know if this is not working for them to hear, but if the presenter, we've been asked through somebody else's email to repeat the question, if the speaker could repeat part of the question at least, if it's a long one, so that our folks on the outside can hear and participate. Whose hand shot up first?
Thank you. Can you hear me? Great. So I'm a couples therapist, and I was wondering if you'd looked at whether they had attachment issues, your participants had attachment issues later on in life with romantic partners, and whether someone who had experienced childhood abuse, they're more likely to experience abuse as adults. I know that that's true, but I wonder if that changes, if they've also had abuse as adults, if that changes how they react in social situations, if it makes it worse, or if they have corrective experiences by not having adult abuse.
So the question was two parts. So first, focusing on whether the child abuse leads to more abuse in partner romantic relationships, and also more so about how the couples are interacting. That was more so the second part, right? Yeah.
Whether it, if they experience abuse as
right.
As well in childhood, if that makes their outcome worse.
I'm not entirely yet, and we haven't looked at that in our data, and I'm not entirely familiar if there has been. I'm sure there has been research. It isn't an area that I've really looked at, but something that certainly could be done, and within this study as well that we'll be targeting, because of the qualitative interviews, we'll have both the person going through the intervention and also their spouse or partner to examine whether or not there are differences in their communication processes. So we'll be able to examine how the state of their communication before the intervention, and also whether or not that has changed or developed over the course of the intervention. But yeah, those are important things to consider, and yeah, I'll definitely keep those in mind. Thank you.
Thank you for your lecture. My name is Melissa Laddick. I'm a PhD student at Hopkins, and my research dissertation is on self-management and self-efficacy and biomarkers. I'm just wondering, I can't remember, are you also having a biomarker component in your intervention?
Yes.
And so you're looking to see if your intervention decreases their inflammatory biomarkers?
Right, correct.
Okay.
Yeah. So we'll be collecting saliva at the pre and the post, and then at the 3 and the 6 month follow-up to examine whether there are any short-term but also long-term effects.
And I'm just curious, what made you choose IL-6 and I think DHES as opposed to other biomarkers, or increasing the panel, because obviously there's so many.
Right.
And there's also pro and anti-inflammatory. So I'm just curious your thinking on that.
There's quite a few to choose from. That's correct in terms of which biomarkers to include. For us, we chose these two because in previous interventions, they've been shown to change, or they're reliably able to change and share common outcomes of childhood abuse, have been shown to be mechanisms or mediators. And also, I mean, the more design issue is that there's only, so much money to really, we weren't able to really do a full panel. And in terms of being able to get to the participants and collect the saliva is a lot more straightforward, as opposed to having them come to ASU and collect blood. And luckily, we have Doug Granger on campus, so we can his building's next to mine, so we can just walk on over and give them the samples when they're ready to analyze. But certainly it would be great, to really expand it out. But when working and these sorts of different design capacities, these sorts of decisions have to be made,
Hello, yes, Sandra Hoforth, University of Maryland, School of Public Health at College Park. And I had a question about your time scale. It says you mentioned the importance of it. Could you give some examples of, for example, I can think some of your reactivity is in a very short term, within an hour or two, but other ones might be over a longer period. Is that what you're meaning?
Right, so the question was focusing on the importance of the time scale. Right, so depending on your research question, so in my program, are individuals with a history of childhood abuse more physiologically reactive to daily stressors? So then in terms of designing the research study, we would want to maybe collect saliva 4 times over the course of the day to examine whether or not it influences their diurnal pattern. Whereas in the intervention, we're more so interested in more inflammatory markers that are likely to change over this time period of months, and so those observations are going to be more spaced out.
I see. Yes, I'm managing a web-based program for the American Time Use Survey, which has diaries for individual days, so you can get very detailed information at a national level for people in the United States on a daily basis. And other studies have done it over with monthly or through the year. So there are a number of actual national studies out there that have some information that could be useful.
Thank you.
One more question.
Hi, I'm Sunmi. I'm a postdoctoral fellow at NHGRI, and we are also trying to do a study to improve social relationship in caregivers, to improve their health status. And we are also using biomarkers to assess their physical health status. And I think your social intelligence intervention is very interesting. And I wonder if you saw any improvement in their health behavior after receiving those interventions.
So right now we've had 25 people who have gone through the intervention and control, so we haven't been able to look at that quite yet, but we certainly have measures of that, both pre-test, post-test, and then the follow-up. And it'll be interesting to see whether or not this does influence their health-related behaviors. It's definitely on the list of questions to be asked. Yeah. Thank you.
I'll see about making it cooler after I turn things over to our next presenter. But one of the things I've noticed from the 20-year Hickman vision and subsequent presentations are and an issue that influences us all are the desire for the most comprehensive or exhaustive, biomarkers, and yet the constraints of patient safety, patient overload, patient burden, and so when patient blood, yeah, and and transportation issues and everything else, and so when we get to brainstorming, I hope we might spend some time thinking about the intersection of the most useful biomeasures or imaging that we can get crossed with consideration of patient and participant time and burden. That's all. Just a little. Thank you. Do keep that in mind because it does keep coming up. And I'm sure it also comes up in weekly research staff meetings, too. First, though, I thank you, Frank. Both Frank and our next presenter are OpNet grantees from this fiscal year's administrative supplements on these basic mechanisms of self-management. So please welcome Sarah Sanders Chaser from Vanderbilt University.
Hi, thank you. I apologize for my delay this morning, and I'm really excited to be here, and I'm looking forward to the roundtable discussion later and hearing everyone's talks. So today I'm going to be talking about sleep duration and quality and self-management of type 1 diabetes. I am a clinical psychologist with expertise in pediatric psychology, and much of my work has been focused on self and family management in youth with type 1 diabetes. So today I'm going to give you an overview of the tasks of self-management in type 1 diabetes, highlight some of the known barriers and facilitators of self-management in this population, and then talk about potential effects of sleep on diabetes management, share some preliminary findings from our data, discuss the next steps, and summarize. So for those of you who aren't as familiar with type 1 diabetes, it's one of the most common chronic childhood conditions. There's approximately 18,000 new cases diagnosed each year, and the incidence appears to be rising based on national data. The mean age of onset is 10 to 14, so a lot of kids are being diagnosed at a tricky developmental stage. And despite advances in treatment, including new technologies and better insulins, there's still an estimated loss of life expectancy of up to 13 years. So it's a very serious chronic condition. The goal of treatment is to maintain glycemic control as close to normal as possible to prevent acute and long-term complications. And the majority of this treatment regimen is completed by the individual and his or her family. So this slide shows you all of the tasks involved in self-management for type 1 diabetes. So one of the frustrations that we hear from patients and their families is that people tend to be more familiar with type 2 diabetes, and so they have some misconceptions about management for type 1, but it really is quite intensive and demanding. So I'm going to kind of run through these so you get a sense of this. Hopefully I can find the pointer. So it really starts with blood glucose checks, and patients are expected to check their blood 4 to 5 times a day, so when they wake up, before each meal, and at bedtime, and that really provides the information that is needed to make decisions about other management. So the next step would be logging those blood sugars either electronically or old-fashioned paper and pencil, and the reason we ask patients to do that is so that they can start to see trends and determine if they need to make adjustments to their insulin. The next piece that can be quite challenging is counting carbohydrates. So the treatment regimen is really built around trying to match insulin to the carbohydrate intake. And so every time patients eat anything, they have to read the label or learn about how many carbohydrates are in that food, and then either enter that information into an insulin pump or calculate a ratio to determine how much insulin they need to give. So that's what goes along with this giving meal and snack insulin. And this is something that, especially for teenagers who can be kind of self-conscious and may not want to share that they have diabetes, this is something that they might try to avoid doing in front of others, and that can be really tricky if you're thinking about school lunches or going out with friends. They're also giving long-acting insulin, and again, that's either with injections or with an insulin pump, and that's to maintain blood glucose levels overnight and throughout the day. And all the while, they're monitoring for hypo and hyperglycemia, so low blood sugars or high blood sugars that they need to treat. And as I mentioned, they are learning to recognize glucose patterns and make adjustments to those insulin doses. And in order to do that, they have to communicate with their provider between visits as needed if they find that they're waking up low every morning or every afternoon before a snack, they're high. So there's a lot that's involved. So it's not surprising that adherence rates are quite low, especially among teenagers, and that it's very burdensome for families. So we can see here that the proportion of patients meeting the treatment goals really falls off once you get to the teen years. And so these data were based on A1C target, which is a measure of blood glucose levels over 8 to 12 weeks. And these goals have actually been adjusted, and so even fewer are meeting these targets now. But at the time these data were collected, over 60% of the youngest kids ages 1 to 5 were meeting the goals. And that's likely because at that age, parents are really the ones responsible for treatment management. And then you can see in the middle childhood years, it's less than 50% were meeting the target. And once we get to the teen years, it's hovering around 20%. So we're not doing a great job of helping these families to meet these targets. And one of the reasons is that the self-management is so difficult. So the most objective measure of self-management, because there's so many tasks involved, is how often people are checking their blood glucose each day, because that's really what forms the basis of all these other decisions. So the recommendation is really 5 or more times per day. So that would be the blue and gray lines. And again, you can see here that those youngest ages, 1 to 5, they're checking 5 to 6 times a day. Some of them are probably checking more than they need to. And that's because these are hypervigilant parents who are doing the checking. And so especially with a child that young who has diabetes, the parents are really worried about them. They're on top of these things. So they're checking multiple times a night often to make sure that they're not having low blood sugars overnight. So then in the middle childhood ages, they're still doing a fairly good job of checking regularly. But you see it really drops off once we hit the teen years, and then young adults are actually probably the worst about this. And so if you're only checking 1 or 2 times a day, it's really hard to make all those other decisions about what you could eat, if you're able to participate in strenuous activity, because you're always trying to kind of balance those needs of insulin. So there's been a lot of literature looking at barriers and facilitators to self-management in this population, knowing that they do struggle a lot with self-management. So one area that I've been really involved in is the role of parental involvement as either a barrier or facilitator to self-management. So as you could see from those previous slides, parental involvement is really important, and it's when parents stop being as involved in the teenage years when we start to see a real drop-off in self-management. So we know that continued involvement is important throughout adolescence, but that the type of involvement is really important. So I've done some observational work showing that collaborative involvement, or warm parenting, where they're trying to work together with their teen to talk about decisions around diabetes management, praising their child for any kind of self-management that's happening, that is related to better outcomes, better glycemic control, better quality of life. But when the involvement is intrusive or nagging, questioning them a lot, why is your blood sugar so high? What did you eat? What happened? That type of involvement is related to more depressive symptoms, lower quality of life in the teens, and poor glycemic control, because they kind of just tune out. Diabetes burnout is a big issue. As you can see, there's so many tasks involved in management, it's hard to keep up with it all. And we frequently hear from both teens and their parents that they're just sick of diabetes. They wish they could take a break. They're tired of doing all these tasks. Stress is, of course, a big issue for these families. We measure this in our studies, and the most common source of stress is daily diabetes care. So it's the self-management piece that is just the chronic stress of having to do all of these things every day. But for teens, there's also stress related to feeling different from peers. So some of the developmental issues that you might expect, seeing their parents worry about them and feeling like their parents are nagging them. And then health numeracy is an area that some of my colleagues at Vanderbilt have really highlighted as being important for diabetes, especially because numbers are so involved in their management. So sleep is something that hasn't been looked at a lot in type 1 diabetes, but that I'm interested in pursuing as a potential barrier and facilitator to self-management. So I'm going to talk a little bit about why we think it might be important in this population. So looking at data from the general population and other specific populations that might be relevant here, we see some physiological effects of sleep disturbances or insufficient sleep. So in obese adolescents, there's data showing that they have higher blood sugar and that there's increased evening cortisol and growth hormone levels and decreased insulin sensitivity. And in adults with type 1, there's poor glycemic control when they're not getting sufficient sleep. So the piece that I'm actually more interested in is the behavioral effects of sleep on diabetes management. So again, looking at data in other populations, in the general adolescent population, we see that insufficient sleep is related to poorer food choices. So they're choosing foods that are higher in calories and carbohydrates, which is potentially an issue for kids with diabetes. And they also report less physical activity and more sedentary time when they're getting less sleep, which I think we can all relate to. When you're tired, it's hard to be motivated to make good food choices or go out and do physical activity. And then in one of the only studies that has actually measured sleep in adolescents with type 1, they found that they exhibited more behavior problems such as aggression, and that they had academic difficulties, so their grades were lower. Which brings us to likely cognitive effects of sleep on diabetes. So again, from the general population, we see that sleep disruptions and insufficient sleep are related to reduced blood flow and decreased activity in the prefrontal cortex. And that's the area of the brain that's really responsible for those executive function skills, which we heard about earlier, which are so important for goal-directed behavior that is going to be needed for self-management. And there's some studies of sleep deprivation where they keep people up all night or they really restrict their sleep, and they've been able to show that that has a big impact on cognitive flexibility and sustained attention. And those are two of those executive function skills that are important for self-management. So why do we think that this would be important in adolescents with type 1 diabetes? Well, we know that most people aren't getting enough sleep. This has been in the news a lot lately, and especially teens. So national data show that over 80% report insufficient sleep, and that's going by 9 hours per night, which seems like a lot, but that is what the National Sleep Foundation recommends for adolescents. It's actually 9 hours and 15 minutes per night. So if you have a teenager, you can tell them that's how much they're supposed to be sleeping. But it's easy to see why teenagers aren't getting that amount of sleep. So there's quite a few developmental changes that happen during the teen years. So there's physiological changes. There's a shift in circadian rhythms so that their body wants to stay up later and sleep in later. So what I like to call the vampire schedule, where they're up all night and sleep all day, there's a biological reason for that. So when we ask them to get up for school at 6 a.m., it's really challenging. So that brings me to the environmental changes. Unfortunately, a lot of times teenagers are expected to start school earlier, so high schools often have the earliest start times. I know in my school district it's 7:15, so if you have a teenage girl who wants to do her hair before school, like they're getting up pretty early to get that done and get to school on time. There's been some public health movement towards shifting school times later for older kids, and I think they've seen really promising results from that, but I think the vast majority of high schools are still starting earlier than elementary schools, which should probably be flipped. And then there's a lot more demands on teenagers after school, so they have more homework. A lot of them are involved in sports or extracurriculars that take up hours and hours after school. More teenagers are working after school, so that's affecting the ability to go to bed early. And then there's social changes, so I'm sure we're all familiar with the increased time on social media, so that includes things like texting with their friends, Facebook, Instagram, Snapchat. Even gaming has become more social, so kids who are playing Minecraft with their cousin who lives in another state, they're talking to them on their headset, or that's how I imagine it. So there's also less oversight by parents at this age, so a lot of times we'll talk to families and we hear parents say that like they go to bed before they're teenagers, so they don't really know what they're doing at 2 a.m. A lot of kids keep their phones in their room at night, and so every time they get a text or a post, a message or anything, their phone's buzzing and disrupting their sleep, waking them up, and then they check their text, and then they're all upset about somebody was invited to a party they weren't. So there's a lot going on for them that can get in the way of getting sufficient sleep. So that brings us to our hypothesized associations here. So this is taking all these data from different populations and trying to pull it together for adolescents with type 1 diabetes. So we expect that there's a bi-directional relationship here between glycemic control and sleep. So kids who are in poor glycemic control might have more sleep disruptions because physiologically they might be drinking more water during the day, so they have to get up at night to use the bathroom. There's some studies with polysomnography that show that they spend less time in different stages of REM than people without diabetes. But at the same time, the evidence suggests that sleep can have a positive effect on glycemic control. directly, but also indirectly through these effects on cognitive function and then the behavioral self-management. So it all kind of loops back around. So what we're interested in is really studying these two so that we can see if we could intervene on those to improve self-management and ultimately glycemic control. So we have an ongoing study that's aimed at improving adherence, and we were able to include a sleep measure in this. And so I'm going to share a little bit of preliminary data on this. So this study wasn't designed to intervene on sleep, but we're looking at the baseline data here. So it's 120 adolescents, ages 13 to 17, about half female, predominantly white, but that's true for type 1 diabetes in general. And we had a pretty wide range in income categories with a median income of $40,000 to $60,000 family income. In terms of clinical characteristics, our mean A1C, which is the glycemic control, is 9.1%, so that's well above the target of 7.5%. Looking at BGM is blood glucose monitoring, so looking at that objective measure of self-management, they're expected to check 4 or 5 times a day. Our mean was 3.3 checks per day, so again, they're not meeting those targets, and the standard deviation there was quite wide, so there's a lot of variation there. And about half were using an insulin pump, half administer insulin with injections. And when we looked at our self-report of sleep in this population, the mean was 7.6 hours a night, so it's well below that target of 9 hours a night. So here I have bivariate correlations between these variables. So in terms of sleep duration, greater sleep duration was related to better adherence. This is the self-care inventory, which adolescents complete. And the sleep quality, the way this measure works is a lower score is better. So a higher score on the sleep quality measure means they actually have poor sleep. So the association is in the expected direction here as well. And then in terms of executive function deficits, and this is based on a parent report of the child's executive function, so how well they're able to complete tasks, stay organized, get things completed. We found that sleep disturbance, so that's things like waking up in the middle of the night, having trouble falling asleep, was related to more executive function deficits. So our next steps, with help from the OPNA supplement, will be to collect objective measures of sleep in adolescents. So we're going to be using actigraphy data, which means that they wear an actigraph watch for 10 days, and that measures movement, very subtle movement, probably better than a Fitbit. And so it will tell us objective measures of sleep latency, or how long it takes them to fall asleep, efficiency, so this is how much movement there is during the night, and total sleep time. So up till now, we've had to rely on adolescent self-report in our data, so this will give us a much more objective measure of sleep. We're also asking them to complete sleep diaries for those same 10 days, and that will tell us a little bit more about some of the things that might interfere with sleep, like caffeine use, after-school activities, school start times, media use at night. And then we'll be conducting cognitive testing using some of those neurocognitive tests that we've heard about today. So we're really focusing on the executive function tests. So the NIH Toolbox has 2 measures that we'll be using. The WISC subscales of digit span and picture span, which measures working memory, the ability to kind of hold those numbers in mind and repeat them. And then TRAILS is where adolescents are asked to draw a line from A to 1 to B to 2. So that measures sustained attention and processing speed. And then we'll continue to collect multi-method measures of self-management. So the parents report on the adolescent's self-management, the child's report on their own, and then the meter download, which gives us those objective number of checks per day. And our goal is really to determine the modifiable aspects of sleep in youth with type 1 diabetes so that ultimately we could intervene to improve those. So to summarize, sleep disturbances are prevalent in the general adolescent population, and it appears that this is also true in teens with type 1 diabetes. Sleep may serve as a barrier or facilitator to self-management in diabetes, and we would expect other chronic health conditions. And therefore, increased understanding of sleep as a basic behavioral mechanism in relation to self-management has implications for both diabetes and other pediatric populations. So I want to acknowledge our support from NIDDK, as well as this OPNET supplement, and mention my collaborators. Beth Mallow is a neurologist with expertise in sleep medicine at Vanderbilt, and Bruce Compass is a clinical child psychologist with expertise in neurocognitive deficits in a variety of pediatric populations. and then my wonderful research staff, without whom none of this would be possible. So thank you very much, and I'm open to questions.
Questions for Dr. Jatzer?
There's one back here.
How often are you doing the testing, the cognitive testing?
For this, we're just going to do it at one time point, and then this is sort of just to kind of give us an idea of what's going on in a snapshot of time.
Hi, I'm interested if you could explain a little bit more about your measures of self-management. You talked about patient report and self-report from the adolescents. Is that related to whether or not they're initiating or doing the steps that you showed for management, or is it just related to checking their glucose levels? So are all of those steps what they're self-reporting on? So just a little bit in how you score that.
Yep. So we use the self-care inventory, which has been validated in this population. And it includes both a adolescent report, self-report, and a parent report that's basically asking the same questions. And so it's, I believe it's 14 questions. So it tries to capture all of those tasks. So things like counting carbohydrates, adjusting insulin, giving long-acting insulin, blood glucose checks, adjusting activity and diet depending on blood glucose levels. And it is scored. There's actually a mean score. So for each item, they rate from 1 to 5. I do this none of the time, not very often, up to most of the time. And so I think we actually have found that it's correlated with glycemic control fairly well. Even the child report, which you would expect they might have some social bias and try to report that they're doing more than they are. But I think having the scale give them the opportunity to, it's not just yes or no, it's sort of like, well, hardly ever up to most of the time. I think that they're a little more truthful because of that scale. So then we get a mean score, and our mean scores tend to be around 3. So I think they're being fairly honest. Does that
So it's
answer
a
your question?
self-care scale that's disease-specific to diabetes?
Yes, it is. Yep. Yes.
Hi. I'm wondering if two things. One, can you learn some of these steps so that you don't have to count carbohydrates and think about your exercise, so that you're able to intuitively, modulate your food intake, your exercise, and so on? And then related, if the adolescents are not doing it very well, are they also experiencing negative consequences? So can you see measurements of really poor adherence or poor management?
So the questions are, can you learn these skills so that you don't have to do all the steps, and then are there negative consequences? So one of the hard things about diabetes is that there's so many things that play into that blood glucose level that I don't have type 1, so I can't speak from experience, but from working with these families for several years, you could eat the same thing twice and have a different blood sugar afterwards. So things like stress can make your blood sugar go high. A lot of times we'll hear from kids that, they've figured out how much insulin they need to get through basketball practice, but if it's a game, now you've got adrenaline and it changes everything. And so sometimes they purposely run high before a game because they know they're going to drop low and the adrenaline wears off. So there's this constant adjustment. And so the way that type 1 diabetes used to be managed was much more regimented, where people were on sort of a meal plan, and they would always give the same amount of insulin, and because they would always eat the same amount of carbs at each meal. And so the management has really shifted to make it more flexible, but because of that, I think there is a little bit more of this math that has to happen all the time. So for some of the families where kids are really struggling, we'll almost shift them back to that sort of like try to get them on 2 shots a day so you're at least covering something. And taking away some of that intensive management. But unfortunately, there's not like a magic formula that you can learn and just sort of stick with it. I think a lot of kids will end up eating the same things, especially for something like breakfast, like they always have a granola bar and a yogurt or something like that, because then they don't have to kind of do the math. They know, okay, that's 20 carbs or whatever it is. And then kids try to cheat it. So there's the magic. I'll put 60 carbs in no matter what I eat. I talked to this one giant football player who was saying he didn't usually give insulin for his snack after school. And I was like, well, what's your snack? And he said, well, usually 2 sandwiches. I was like, well, that's probably quite a few carbs. So I think that it's challenging. And they're
making them with lettuce wraps.
Yes, I don't think that this guy was making them with lettuce wraps. So unfortunately, there's not just sort of a rote memorization that they can use, because there's constant adjustments, and hormones play a role, and growth. So especially during adolescence, it's really tricky. In terms of negative consequences, physiologically, they will feel bad if their blood sugar is high. So they'll experience problems with concentration, sometimes vision issues, sometimes feeling dizzy. But it has to be pretty high for that to happen. And so a lot of times people will be running in the 200 to 300 range, which is still unhealthy long term, but they don't have any sort of immediate consequences. Does that make sense? I think there's questions over here.
One last question, quick question.
In terms of your intervention, do you see along the road of incorporating technology, particularly with teenagers who seem to use the technology more frequently and get more engaged in terms of identifying their carbs, et cetera, and maybe programming with an engineer or another professional?
So the question was about incorporating technology in interventions. So there's been attempts to do that. There's several text messaging interventions with just reminders. And what we see is like an increase in self-management, and then it kind of drops off. And so the idea is that it has to be more than just reminders. There has to be some engagement. There's been a lot of work around developing new apps and things like that. The issue is the kids who are already doing a pretty good job are the ones who like using those apps. And so it's really hard to engage the kids who don't want to even think about diabetes, who are really experiencing diabetes burnout. So we're constantly trying to figure out ways to do that. So our current intervention uses text messages to send positive affect messages to sort of engage them in that way. Thank you very much.
Gosh, I hope so. This is you. That's it. You got it. Okay. How do I just move down?
And you can use this to move the arrow, or you can use traditional arrows.
All right. Good morning, everybody. I think it's very appropriate for me to follow that talk, since I'm talking about youth and self-management, and I'm also sleep deprived thanks to coming from LA and having delayed airplane rides coming over. But I'm asked to talk about virtual social support for youth around treatment adherence to HIV medications, and I'll talk a little bit about my study. I have no conflicts to present, and thanks to the ATN and NIH for funding some of my research. I should say I'm a physician in adolescent and young adult medicine. I didn't start off as a researcher, and maybe that'll be a little bit about why we chose pragmatic research. The issue around adolescents and young adults with HIV has to do with this slide, and see if I can walk you through it here. There are estimated 79,000 adolescents and young adults up to 29 living with HIV. Of those living with HIV, only 40% have been diagnosed. A small subset of that have been linked to care, retained to care, and then those only retained in care, only about half are actually have suppressed viral load. Suppressed viral load is very important because if you think about the epidemic, you want people to be healthy, but you also don't want them to transmit HIV. And these are the people that are transmitting HIV. And if you could get all of these people here to be over here, we would no longer have an why do youth living with HIV have such a hard time managing their condition? Well, there was a really nice study funded by ATN called 086106 that studied youth at 20 different sites across the country, and virtually everyone at these sites were actually engaged. So it gives you a pretty good snapshot of what youth with HIV look like. The mean age was 21, 76% were male, 2/3 were African American, 20% Latino, 3/4 were gay, bisexual, transgender, questioning, and 60% were diagnosed in the last 2 years, so new to care, newly infected. And in terms of risk characteristics, you can see here that a good percentage of them were high school dropouts, very few were employed. Stably housed at that time was actually pretty good, but there was a high history of homelessness. 27% of youth linked to care were virally suppressed. 63% scored a 2 or greater on the CRAFT, which indicated substance misuse or abuse. 52% had scores on their BDI consistent with clinical depression. And again, as mentioned, 75% of these youth who were not on medication, who were not virally suppressed, reported unprotected sex. Again, indicating why we're going to have a hard time controlling this epidemic. So there's been a lot of research on predictors of non-adherence in adolescents and young adults. And depression is the one that's kind of chronically up there in almost every study looked. But there's other predictors, including low self-efficacy, poor coping styles, poor social support, poor motivational readiness, housing instability, and substance abuse in some studies. And there's some suggestions in the literature that stigma and disclosure are issues around adherence, although that's been less studied. If you ask youth why they're not adherent, they give you a little bit different answer. They usually say, I forgot, I don't feel like taking my medications, or taking my medications reminds me that I have HIV. I mean, the issue around this is really that youth don't see taking medication for an illness that generally has no symptoms as a very high priority in their life, and there are multiple other things that are of a higher priority in adolescents and young adults than managing an asymptomatic disease. So very quickly, we'll summarize the interventional adherence research to date. There have been a number of studies, one using, all of these are generally been small pilots. One used directly observed therapy, where kind of an adherence counselor went out and gave the medication to youth every day. There was another one using motivational interviewing by Dr. Narking that I work very closely with. There was a study looking at multisystemic therapy in fairly young, perinatally infected adolescents, again, using the family. There's a study that we did initially that used phone call reminders. And lastly, a couple studies now by Dr. Daushin and Dr. Garofalo looking at text messaging. All of these studies showed modest improvements in adherence, but unfortunately, at the end of these studies, adherence went back to their baseline after the conclusion of the study. So there was really no sticking power to these interventions. So being a physician and trying to come up with something pragmatic, I designed what's called ATN 078, which is cell phone support for youth non-adherent to antiretrovirals, and here are all my protocol team. And the methods around the study, this was a longitudinal experimental design. We randomized 37 subjects, ages 15 to 24 weeks of cell phone support. Youth were recruited from 5 ATN U.S. cities, and we used primary adherence facilitators to make these calls and talk to these young people very briefly every day. We purposefully had them be BA-level case managers, research assistants, and not licensed clinical personnel, because we were worried about kind of who would actually implement this in the real world if it worked. So again, inclusion criteria you can see listed. They had to have a history of non-adherence to one or more components of their antiretroviral therapy. They had to be either currently prescribed antiretroviral therapy and report less than 90% adherence and a viral load greater than 1,000, which was 14 youth. The most common group of our patients were ones that had actually stopped taking their medication, which we see all the time, and one youth who had agreed to initiate antiretroviral but never initiated treatment. They had to speak English and provide informed consent. The procedures here are that youth had a choice. Again, this study took place about 5 years ago. At this time, youth didn't ubiquitously have their own cell phones, so we gave them their choice of either using their own phone and then providing an incentive of 45 months to pay for their service, or to receive a phone and a cell phone plan. And again, it reflected the type of plan reflected what was available 5 years ago. What youth had to do to get their incentive was to answer 80% of the phone calls. If they missed 20% of their calls 2 consecutive months, we took their phone away and we dropped them from the intervention. The reason behind this is we really, really wanted youth to get the intervention to see if it would work. Again, and if youth using their own phone were less than 80% adherent, we gave them a phone in service to make sure they would have contact. The calls were made on Monday through Friday. They either received 1 or 2 calls a day, reflecting the number of times they were taking medication. Most were just on once-a-day medication. The goal was to call them about an hour after the time they were supposed to take their medicine, so we were giving them the chance to take their medicine initially. Calls averaged 3 to 5 minutes. They were very brief. And what the intervention was it confirmed that youth had taken their medication. If they hadn't, we waited for them to take it if they had it available there with them. We discussed new or ongoing life problems with brief problem solving. We reinforced prioritizing medications. We scheduled referrals as they needed for physicians or psychologists or their case managers. We gave them their appointment reminders, and we assessed service utilization on the calls as well. The primary objectives were to look at therapeutic success at the end of the 24-week intervention and 24 weeks after the intervention, as measured by self-report and viral load. We also did some qualitative work with kind of how the youth felt about the intervention and how the adherence facilitators who administered it, and I'll talk about both. At the time, this theory about e-health interventions was not available, but it came about, so I thought it was really worth talking about, which is the theory of supportive accountability. This theory was developed to, again, specifically guide e-health interventions. It's based on the premise that human support increases adherence through accountability to a coach. In our study, that was an adherence facilitator. That this coach is perceived as trustworthy, knowledgeable, and benevolent, and that there's actually speculation in this theory that less face-to-face and more indirect communication actually is attributed with more positive, idealized attributes of the coach. So there's actually benefits to not being in person. And this is, I'll not go through this, but you can see the model here with improving adherence. So we did an ACASI interview that measured a whole host of different measures you can see listed below, including adherence measured by visual analog scale, again, self-efficacy, coping, social support, motivation for adherence, substance abuse, mental health screening, and health utilization. And here you can see the data, and I'll take you through this very quickly, just to say 2/3 were male, 1/3 female, 2/3 were African American, again about 20% Latino, and about half and half behavioral and perinatally infected youth. So we looked at adherence, and again at baseline, adherence was extremely poor in this group, under 40% in the intervention, the control group. You can see at the intervention, at the end of the intervention at 24 weeks, adherence went up, and at 48 weeks it stayed up, and it was statistically significant, regardless of whether you asked them in the last 3 months, the last month, the last week, or the last weekend. Of note, the adherence in the control group was even worse than it was at baseline at the end of 48 weeks. And these kids were all in care in adolescent young adult sites with psychologists and doctors and stuff like that. You can see that greater than 90% reported adherence, which at the time was the gold standard, was also statistically significant regardless of how we looked. Of course, self-report doesn't always reflect what's really going on in the real world. So fortunately in HIV, we have a biological measurement, meaning viral load. And you can see again that over the 48 weeks, viral load was significantly reduced. Of note, if you look at kind of what we want to get, which is an undetectable viral load or close to undetectable, a little over half of the youth in the intervention reached that at 24 weeks. It dropped a little bit at 48 weeks. So certainly this didn't work for everybody, but it worked for a good chunk of these youth. We also looked at feasibility and acceptability. Only 12 of the 19 subjects completed the intervention, but what we found is that if we would have reduced that requirement from 80% to 75%, 5 additional youth would not have been dropped from the intervention, so it'll help us with the next round of studies. Most youth participated. 84% of all the calls were completed. Reasons for missing medication prior to the call were forgetting, 23%, change in schedule, change in routine, kind of what I presented from other research. In terms of the call content, problem-solving advice was given in only 6.7% of the calls. So most of the calls were quick. Yes, I've taken my medication, everything's going okay, and it went fine. But sometimes we had to help them with information about reminders and cues and scheduling and managing side effects. And 5% of the calls had a actual referral for one of their service providers. In the exit interviews, 94% of the youth reported that talking to their adherence facilitator was easy. 88% reported getting calls made taking their medication easier. 69% reported more motivation. 95% reported the call length was in the 3-bear methodology was just right. 81% would have liked to continue with calls even at the end of 24 weeks. I thought this was really telling. 63% of the youth actually would have wanted calls on weekends. I would have thought that would have been very low. 56% would have liked to taper the call frequency at the end and not have just been abruptly ended, and 100% would recommend this to their friend. So what about the other impacts of this intervention? We were kind of happy and I guess surprised at some level to find significant reductions of substance use at 24 or 48 weeks. So it wasn't really addressed on the calls, so it was kind of a little bit surprising. We did find significant reductions in depression at 24 weeks, but not at 48. We had significant reductions in perceived stress at 24 and 48 weeks. There was a trend towards improved motivational readiness at 24 and 48 weeks. And we had hypothesized that the reason this intervention was going to work is because we were going to get these youth to utilize more services. They were going to go to the doctor more. They were going to detect their depression, go to the psychologist, go to their substance abuse counselor. But actually, we found the opposite, that they actually was absolutely no increase in service utilization to power this, actual changes in substance abuse and depression. So in conclusion, youth and adherence facilitators basically said that the intervention was acceptable and feasible. Youth in the intervention group reported improved adherence, and that was confirmed by improved viral load. We were surprised a little bit to see the improvements in depression and substance abuse without increasing service utilization. And this is the first controlled study in non-adherent adolescents and young adults to not just show improvement during the intervention, but to have some staying power a full 24 weeks after the intervention. So what are the future questions? What does this really kind of make us think about? Would youth engage in the intervention if there wasn't an incentive?
So in this youth, we use the incentive not to get them to take their medications, but to answer the calls. And we don't know if they would actually answer calls. My experience with youth is that they won't. Other questions include, could we, for some youth, make this more kind of easily administered intervention by using daily text messages alone? Would it actually help to have professionals do the intervention and answer these calls, especially maybe if they were trained in motivational interviewing? Other outstanding questions include who learned to self-manage in that 24 weeks and who actually needs ongoing intervention. And again, can this intervention be utilized to improve engagement and retention of care, which I showed you on that initial cascade is also a huge issue. So it kind of makes me think about some key questions here, which is, who are these non-adherent youth? And, you know, I think our research and experience says these are youth who have very poor social support. They have substance misuse and abuse. They have significant mental health issues. They have asymptomatic, stigmatizing condition. They may need an incentive to initially engage in any intervention. Study adherence facilitator may be the only reliable person in these young people's lives. We didn't ask this, but kind of at the end of the study, this was my big thought, is do these people really have anybody in their life who's going to actually talk to them pretty much every single day and be supportive? Can this support eventually lead to self-management, and can text messages or apps provide the same level of support? I am involved with 2 other studies right now. One is using a web-based intervention that uses motivational interviewing principles to help youth new to care engage and start medication, and another intervention study, ATN 132, that's just starting right now, that's using an app for young men who have sex with men, gets them into some chat room like interventions to try to provide social support and see whether that can help them with social support and not have to have that required person-to-person intervention. So a lot of people to thank, our community advisory board, the subjects, NIH, and I left a bibliography here at the end for people. Thank you. Yes.
May have had an impact.
Yeah. So in the original pilot, not this pilot study, we had just done reminders and found, like all these other studies, that if you just provided reminders, they take their medicine, and as soon as you stop the intervention, they go back to where they were before. So we tried to be able to say, could we provide some level of brief support? So if you think about adolescents and young adults with HIV and all the problems that they frequently have problems in their life. And what I have found as a clinician is that they don't tell you when they have problems. And they tell you when they come back 2 months later, 6 months later, having stopped their medication. So we wanted to find out what their problems were in real time. And the types of problems that they had, sometimes it was just like, you know, medicine fatigue and not wanting to take their medication. And you might be able to help that by giving them either, you know, motivation through this supportive accountability theory, or even just through trying to help them with dosing cues. Where do you put your medicines? How do you remember to take them? Sometimes it was insurance issues in the United States. So many young people lose their insurance or, you know, run out of refills, and you have to help guide them through some of those really kind of pragmatic issues. Some kids had depression or relapse with substances or were homeless, and they needed a referral to their healthcare team. And what this intervention really allowed us to do is to get them that help in real time, not provided on the call. The call was really supposed to be very brief, but detect those problems, because all these youth have a healthcare team that can help them if they have more problems.
So I was wondering whether or not you think that the ongoing social support is. So I recently started using an app that's really helped my adherence where I have an ongoing thing. It's not HIV, but it's something else. And it sends a text message to a friend if I don't take my medication half an hour after I was supposed to. And yeah, it's really helped. And so I was wondering whether or not that sort of, because in that sense, it engages social support only when I'm not taking my medication. And I was wondering whether or not that kind of strategy you think would be helpful, or is it really like the ongoing support even when the medication adherence is going well?
So I guess the question is, do these youth, number one, have somebody in their life that could provide that level of social support? Many of them don't have reliable people, but it could be a service provider who provided that as needed. But then you kind of need the technology to how do you know they didn't take their medication? So there are, MEMS caps and different types of, pill boxes that can send electronic messages out when you don't take your medicine. But they're kind of big and bulky, and they're not the kind of thing that youth like so much. So I think that for some youth, that would be very practical. And I think as we're developing interventions in HIV, the whole idea is, how do you find the easy ones, easy interventions to implement that are inexpensive and, for that first tier of youth who are having a little bit of a problem. And then what do you do with that big chunk of 50% of youth who really have, I think, significant cognitive deficits? We know from our research in ATN that 60% of the youth new to care had cognitive deficits on neuropsychological testing, probably just baseline of what they had. We know these youth have huge amounts of trauma in their life, and it's always hard to ask youth in youth studies abuse because IRBs don't like it, but we're guessing that they do have a lot of that as well. So I think that, you'll end up with kind of some text messaging, some apps, some stuff to tier off some of the easier ones. But at least in this particular population, you're going to need something more personal. We know from many, many studies that youth do not like going face-to-face interventions, especially when it's, these great studies of 10 sessions, or there's even one study with youth that was 24 individual sessions for as the intervention. It's like, you're just not going to get them to do that. They love their phone. It's a great incentive. The question is, I think, will there be great apps and kind of non-personalized stuff for some youth, and then figuring out what the right doses are.
Thank you for this research. It's really interesting. I was curious, looking at something like Facebook, looking where people are already spending a lot of their time. I think one of the interesting things that draws people to it is the kind of seeking of validation, like a Facebook like on a comment, or kind of continually seeking that they're having interactions with their peers, even if it's kind of artificial. So I'm curious if you've kind of thought about drawing people into almost like a social network of peers, but also, I heard you mention this chat room kind of idea, but I think that something where the posts aren't necessarily ephemeral, but other people can go in and look through like other people getting support. And also this way you could scale the ratio of clinician to patient interactions, so that one clinician can kind of be moderating and kind of helping, 10 to 15 youth at once. So I'm just curious what you thought about that.
So Lisa Hightow at University of North Carolina has developed an app through a small business grant, and is doing some of this work. I don't think the actual chat rooms are in real time moderated, but they are moderated where the feedback that goes back and forth between these young people who are all part of this intervention and who are communicating with each other and providing hopefully support. It's just getting ready to start right now. So I think we will see. Obviously, there are always these issues around confidentiality and how do you really control that? And so Facebook would be a great way to to do that, and yet we know all of our patients are on Facebook because that's how we find them now when they don't show up, is sending them a Facebook message, hey, give us a call.
I hear something slightly different that is yet relates quintessentially to the title of this meeting, self and others. Who your interventionist is kind of like a peer plus, right? You made a conscious, informed decision for your interventionist to be a relatively young, non-medical behavioral health professional who comes in with not quite a sup, right? And and so if there and so this is an informed person who does a check-in, does referrals if needed, is there, kind of like an older brother, cousin, big brother kind of intervention. And that seems, I think, particularly important in a multiply marginalized minority population. And I remember you talking about the qualifications and specific lack thereof. Did background research with these young people lead you to that strategic choice?
So I wouldn't say background research led us to that. I think that, there were a couple reasons why. Number one is, who do youth connect with? They connect with the type of people who we would be hiring as baseline case managers or adherence assistants that that kind of what HRSA and, the government has actually funded. Number two, you're right, they tend to be young people who are experienced with, the lives of these young people and people who are very supportive that chose these careers because they like to help young people with, HIV. And then lastly, we did it, because of cost, that we, and specifically not wanting this to be kind of a you didn't want the youth to think of this as a psychological, counseling intervention. They get a lot of that thrown at them. They wanted them to think about it as being a little bit more casual, but also being able to, give them hopefully what they need.
You had mentioned that you've gone further and you have some other studies underway doing the text, and I wondered if you've thought about, because it seems that this has shown that perhaps using some more different designs might be beneficial. So have you thought about using adaptive designs such as the SMART design, where you could keep those youths in and give them a text message or give them different adherence rates with their phone calls or text messaging? The other thing I think is that a most intervention, that to really determine what is the most potent intervention would be important, because though they report the 3 to 5 minutes, you said you did it twice. And there's a lot of things that could make this more potent. So there are ways that you could use pilot data to some extent to do that. So I just wondered if you had thought of using some of the more different designs that are now out there to, seems that this group would especially benefit from these types of designs.
So absolutely, Mick, that's what we're developing as a SMART trial around how to take this at different levels. The problem is, when you want a SMART trial, you want some interventions that actually have some good pilot data to take you to the next step, and that's not really there yet. I'm very interested in text messaging. The problem with text messaging studies with youth thus far is they're very impersonal, that they're just kind of reminders, and even if they ask you to text back, it's not a two-way text conversation, which is how youth, most, at least my kids, live their life, right? They're not talking to people, they're texting back and forth and get a level of support of that. So I'm hopeful that there will eventually be some level of that kind of interactive texting
versus automated. I just don't know which way will turn out to be efficacious. Right, thank you.
Good morning. My name is Sun Mo Yoon. Can you hear me? Okay, great. I'm a postdoctoral research scientist at Columbia University, and I have a clinical background on neurology, mainly about 10 years. And I'd like to present social media network, stress, and depression among dementia caregivers. I have no conflict of interest. I'd like to first introduce dementia caregiving and my past social media mining work. In methods, I'd like to present the process of social media mining, structure mining, and content mining. In results, I'll represent the network structure of dementia caregivers and their tweet content. Alzheimer is the 6th leading cause of death, and we have 5 million Americans suffers from the Alzheimer. And almost 10 million Americans provide unpaid care for dementia. It counts for 8 billion hours of care and 94 billion US dollars. Does anyone have experience of taking care of dementia patients as a nurse or the, we have you, great. So 87 patients are cared for at home, and they have challenges of excessive stress, fatigue, isolation, and loneliness, and of course the financial and work complication. So dementia is overwhelming for the family members. So our team is currently studying the Hispanic dementia caregivers and try to develop the web-based tailored intervention for them, and the self-management supplement is under the review. So my past work includes social media mining for self-management, physical activity in particular. In 2010, my dissertation, I reported the strategies for social network analysis in 3 levels: macro, meso, and micro level, and natural language processing to detect the topics. And I also found that tweets, 42% of the tweets revealed motivation and psychological needs associated with jogging. My Ebola paper just came out in June, and it has been recognized as a groundbreaking finding. And what we found was that the people in Nigeria were spreading the word that, guys, we have a Ebola case in Lagos. Let's wash our hands. Crazy. That's what they spread. And it went to 16 million people. And as you can see, that is a washing the hands is self-management behavior. And we can see it's a perfect example of self-management for the acute disease. But however, what about the chronic disease, which is more difficult? Does anybody use Twitter? Okay, only 3. You are not alone. I only have like 40 followers. Twitter is a short text message system to share feelings, observation, and activities in daily lives. And it is 9 years old, and 300 million active users generate over 500 million tweets every day, which is a lot of data. And it can be a vehicle to measure the public opinion. However, it's largely unexplored, And a lot of studies out there is a descriptive study or opinion. There are very few intervention study. And 20% of the adults who make less than $30,000 use Twitter. Unlike Facebook, many minorities use Twitter. For example, 29% of African American use Twitter, and 16% of Hispanic before was 18, but it dropped down. So for those people who, I'm so happy I have this slide. Or the people who does not use Twitter, the hashtag is for the keywords, and the young generation use the hashtag, the thumb sign, in everywhere, not only in the Twitter. And so that you can highlight the keywords, and you can press the retweet to do the citation. And can you imagine if Justin Bieber ever posts a tweet such as, guys, let's take care of dementia caregivers. Their stress is horrible. My mom is. Then it can reach to 2 million population, our young generation, 2 million population in 1 second, more than Barack Obama. So it's not impossible because he did it for the ALS, which is another neurodegenerative disease, for Ice Bucket Challenge. Twitter has been used in other disciplines and other departments. During Boston bombing, the police department used Twitter as a tool to collect the information and disseminate the information. Probably a lot of you already seen this one. This is a landmark study. So the dotted line represents the CDC flu rates, and the solid line represents the flu rates by Twitter. And as you can see, two lines align a very highly correlated manner. The Lazarus formula guided my analytic strategy. This is a very simple formula, but I love it. It was developed in 1948, and it just helped me tremendously. So to whom they are talking and what they are talking. So that's what I did in 2010, using the Twitter channel. And my future question is, with what effect? I haven't gone there yet. It has been 5 years. But. So this diagram shows the Twitter mining process. Probably you are already familiar. Import the big data, and prepare the data cleaning. 95% of the data and analytics are preparing and cleaning, and reducing the big volume and analyzing it. Oh, it doesn't highlight. Okay. In analysis, as the structure mining and content mining, I contributed in the science for how to analyze both. And then as you can see, there are a lot of software are needed because the social media mining is fairly new. The structure mining is a comprehensive approach to see the multiple level of a network structure. And we have a lot of the measurements. If you have a social science background and network background, probably you know like there are 30 to 50 all different kind of measures. And macro level, meso level, and micro level structure. And content mining is cheap and automatic and convenient way to grasp the main topics of what they're talking. So I wish I had a computer to show this 3D interactive visualization. This network shows the person who mentioned about dementia caregiving in one day, just one quick snapshot from the macro level. You can zoom in, you can see the community structure. Then you can further zoom in, and you can see the relationship among them and their names, usernames. So what they were talking was, I'm sole caregiver to my mom with dementia, not quite the same, but I know the stress and isolation one feels. So this person clearly posted that isolation and stress. So you can see directly there is a need for the self-management. This is two-dimensional, not so much exciting. But the left side mentions the dementia caregiver, and the left side on your left side, and the right side is Alzheimer caregiver. But both of them have overall very sparse with many isolates expressing their feelings. And you can also see the few groups at the core. Can you guess what isolates mean? Right. I didn't expect that you can answer that. So we have implication for that in the discussion. I practiced this talk a lot and nobody was able to answer that. And then let's move on to the meso level. The community, in definition, is a 3 to 15 people who share their common norms, roles. This case is the dementia caring roles and the common purpose. As you can see, only few I found. It was only a very short period amount of time. I only found like 3 or 4 core groups. So now it's your turn. So who do you think was the leader of that community in the Twitter talking about dementia caregiving stress? CDC? Honors? Alzheimer Foundation? Okay, no, all wrong. So the daughters of dementia caregivers. So they are they are informal caregivers. So they act like an authority. They receive a lot of information from wide range of the others and send the information to the large number of others. And I saw they were supporting when another person was posting, and then this person was answering, and I think it's good, and give them the feedback. Now let's move on to the micro level structure, the friendship. Triad census is a dynamic among the communication among 3 people. And there are 16 different friendship styles: balanced, hierarchical, and rank, and forbidden. And in theory, balanced type is ideal communication. For example, my parents and my sister, they have balanced communication style. My sister was asked to my mom. My mom is a caregiver for the dementia patient. The mom, are you okay for taking care of your my grandmother? And my father said, no, it's a lot of stress. And my mother was answering, no, it's okay. Social desirability, right? It's okay. Your aunt is helping. I'm fine. I'm fine. My parents and I, we have a hierarchical kind of a communication style, unfortunately. However, it's also valid because I have a good communication with my mom. So my mom is straight to the point and be very honest and telling me that, Sanu, I'm getting depressed and lots of stress about taking care of your grandmother. And this is my grandmother, 95. So now it's your turn. So which relationship is the worst? Worst communication relationship out of that 16? Right, a second and first, right. Unfortunately, what I found was that the worst communication style, a communication network, were 2 million communication network. And the name is a clusterability, meaning you can cluster them in the future, but now it's isolated. So what they were saying is, I am not very comfortable with their lifestyle and needs, and that this person is a daughter of a gentleman who has dementia, and she has to spend the weekend with her father, and she did not know, she was uncomfortable to be with him. And another person posted, this whole process is hard for everyone. I feel like I should be stronger. And another, you can see the need of the self-management. I also found other types, such as balanced type, but it was less than 2,000. And the ranked cluster too. The ranked cluster is a news announcement, such as a positive outlook can help family caregivers reduce the stress and stay healthy. And read more. Now, let's move to content analysis. I used a natural language processing for it. And now we have other topic modeling, but that time was N-gram-based analysis. The N-gram-based analysis is basically you divide a word as a one word, two word, and three words. Unigram, bigram, trigram. Experience is unigram because it's one word, and bigram is two words. The let go. But if you separate those words, it has different meaning. And keep in mind this is a trigram. This is the results of the 5,000 tweets mentioning dementia and caregiver in August. As you can see, despair, depression, deep, slow, sad, down. You can see the need of the self-management as well. This graph shows the location of tweets mentioning dementia and caregiver in one day, August 17. As you can see, the Florida, which is a retirement place, the tweets are coming from there. And an adventure like no other, you can see the kind of frustration and the need for the self-management and humor soften my despair, and this person used the despair word. This is a sentiment analysis results, and half of the tweets were unpleasant, strain, stress, burden, stressful. This graph shows 3 days of the Twitter sentiment mentioning dementia caregiving around the noon time every day. Unpleasant, unhappy tweets coming out. This pattern is a little different from the physical activity. I usually see the physical activity, the tweets around 9 o'clock and after 5 p.m. and other diseases too. So now let's discuss about the finding. So overall, what we found was that the tweets were not reciprocal, and the many isolates expressed their feelings and their own experience voluntarily, which is very important. So it's not the study kind of setting. Nobody asked. They were voluntarily expressing their own feeling and experience. And as you know, the voluntarily and autonomy is very crucial, the crucial psychological needs for the self-management. In other words, in the micro level, we found that the relationship was clusterability, which is, in other words, is isolate. There were 2 million clusterability triads, so that it has a potential to be clustered and grouped in the future. So from the content analysis, we found that the dementia caregivers' psychological needs too. The dementia caregivers gave and received affection and support from others and expressed stressor and coping strategy. On the top is the stressor and the stress diagram, conceptual framework. An existing community group in the Twitter may be used as a vehicle to support the dementia caregiving in the stress management and to fulfill the human inherent desire to belong and to be a part of something. So again, the belongingness, we found the belongingness that the dementia caregivers had an emotional need to be accepted as a member of the group. So you can see the Twitter may have a potential for self-management and stress management to fulfill the psychological needs like belongingness and autonomy. I use the methods which requires the very minimum programming skill, and I used all the software which is open source. However, the generalizability is greatly limited to the Twitter population, and tool also has the problem. Nevertheless, the Twitter mining is an inexpensive way to understand the dementia caregivers' need in the real world. In conclusion, the social media data provide instant reaction and thoughts from the caregivers and patients in the real world. And the novel application of web mining of social media may provide us the new knowledge to understand about the dementia caregivers and their self-management need. This picture is my Alzheimer walk, and I posted on my Facebook. Thank you so much for your attention. Do you have any questions?
Hi, thanks for your talk. My name is Lindsay Mayberry. I'm from Vanderbilt. It occurs to me that some of the isolates were not using hashtags, and I'm wondering if the hashtag is directly associated, the ability to use hashtags correctly is directly associated with the likelihood of receiving a response from somebody else in the community because they can access and read your tweet more readily. So can you talk about that a little bit?
So those isolates actually were using the hashtag dementia and caregivers. So that way I was able to pull those data.
So,
yes.
Sorry, I don't know, but you could only pull data if they use the hashtag?
Both.
Okay.
But it was quick kind of the project so that I only used the hashtag. Okay. Yes. And obviously, you're right. Your question is valid. Obviously, people do not know how to. I can see that people do not know how to answer because I know people probably if that tweets are seen by others and probably they can answer you and give you some support. I agree with you. Yes.
Any other questions?
Didn't realize my superhuman strength. First of all, your practicing paid off. Just a beautiful, beautiful job. I will tweet whoever you want back at Columbia to testify to that. What is the for these isolates? What is the percentage of, if any, of tweeting back with these users to form that sense of community? I know the number of diagrams that you showed us with the communication triangles and networks, but I'm wondering, these people are, out there isolated with their loved one who's slipping away, and so they are coping by expressing themselves. How much interaction is there with not just these daughters who are the community leaders, but anyone else who might be tweeting back?
So the question was that in terms of the isolates and who can be the possible supporter and who can respond to that tweets. And I think that is our future work for the healthcare providers and also the authorities and the leaders can help for them to become a part of the group, because the micro level, the results saying that it is clusterability means it can be clustered in the future. So I think I see as a kind of my responsibility too. And also whomever used the Twitter, like my friends, I have to ask her to use the Twitter to answer who are the nurses and the healthcare providers. But we cannot force them.
We have time for one more question.
Thank you.
I am aware of the energy levels in this room being a little low just before we're ready to have lunch, and I get to speak next. So I'm going to ask you all to stand up for just a moment.
Lovely idea.
One of the things that I do, one of my incarnations, is that I teach Qigong and Tai Chi Chi. So I'm going to ask you to roll your shoulders back and let your palms out. Bring your arms way up behind you. Inhale, inhale. Don't poke anybody in the eye. And then come down to the center with your backs of your hands together. Okay, come on back down. Roll again. Inhale. And then exhale. Roll your hands together. Now we're going to do one more. Inhale up and exhale down. Shift to a different mode. Open your hands up wide and just squat just a little bit like you're going to gather up energy from earth. And then inhale, up, 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 inhale. Keep inhaling, and now you're going to let it all out with what we call blithering. We're going to do that one more time.
Good.
If your butt cheeks aren't waving in the wind, you're not doing it right. Gather up energy from the earth. Inhale, up, 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 and then blither. Got it. Thank you. I'm where
You get the gold star for best self-introduction.
This has been so remarkably stimulating, and even so, I felt a little like we needed to get some energy going. It has been delightful and a pleasure for me to hear all of these different inputs. It's like we've got this web of many, many different ideas coming together, and where we interface is got a lot of power. I'm excited about being here. Over the last 22 years, I've been working in the field of primarily in health promotion and disease prevention. So most of my focus has been on those, how do you get messages out that people will pay attention to, engage in, and then change their behavior. Most of it has been focused on not just the messages, but cultural adaptations, mostly working with social interactions with lay health workers and the community, promotores de salud. I live in Arizona, so we have a lot of work that we do with the Latino population. And so why am I here for something that has to do with self-management? Although a lot of my work has been around health promotion messages in the context of cancer prevention and screening, I've also been working quite a bit in the last 8 years with breast cancer survivors. And in that context, I think we might be seeing that more as chronic disease management. Actually, it's beginning to be thought of that way. So with that background, I'd like to just say that today I'm going to focus a little less on all of those sociocultural kinds of things and a little bit more on the internal process of what do we need to change inside oneself. How do we shift our internal environment? How do we help others shift their internal environment in order to help create the behavior change that we want to create? Whether it's in the context of getting healthy people to change their behavior and do a better job of preventing, as well as all the way down the continuum to people who are suffering from some kind of disease and have a lot of things that they have to balance in order to manage. So we do have a continued problem in this country with behavior change not being prevalent, the things that we would like people to do, the diets that we'd like for them to adopt. All of those who are involved in public health initiatives find that it's just alarming that the news gets worse and worse. So not only are we struggling to get people to quit smoking and manage their weight, all of those things are there, but we're also struggling with open and continued violence. Well, despite all the things that we as public health professionals try to do, or as health care professionals try to do, we struggle to get past whatever it is that's driving this behavior up and out. And I keep thinking about what is the root cause of this non-management of self. We have this idea that we just have to reach people who think they're in the driver's seat and get them to make their choices, conscious decision making, deal with the rational information that we're giving them, and that they'll buckle down and change their behavior. And the individuals feel like, I'm driving this thing. And yet I keep having this feeling that we're all riding this great big elephant that's going its own way. And we have to be addressing perhaps what is beneath that. So we think we're in the driver's seat, but we get sidetracked at every turn. and what the question to me is, what is this elephant that keeps us from staying on track? I've been doing work with with even organizations like the American Society for or the College of Sports Medicine. I get invited to do things that are more exercise and nutrition related, and I keep working with people who are believing that if we get people to exercise and we get people to change their nutrition, we get them to change their sleep behavior, that we will get the result that we want. And I still keep saying that underneath that, we probably have something that is like the secret sauce that needs to be addressed. And I'm hearing a lot of people in here that are presenting today they're each coming up with the secret sauce is we get them to sleep, we get them to focus their cognitive function better and teach them these things. And I think that we're right on track with that. Those are some of the pieces that go into that secret sauce. So generally, in the public health arena, we look at how to attempt to influence this massive edifice of behavior, and we think of the rational ways, cost-benefit analysis. We do role models. We do things that are helping to change people's attitudes and beliefs, getting them engaged, and we also work with social norms and cultural appeals. So those are all things that are certainly part of what might be helpful in moving this. But what I'm seeing is that there are so many things that are part of the massive or mass of factors that seem to be causing the downfall that we're not addressing. And it isn't that we can address them by going after the rational. So this is a model that was developed with work that I've been doing with breast cancer survivors. And even though I'm looking at adiposity as the outcome that we're attempting to deal with, I think that you could substitute just about any symptom or problem or even disease outcome at the end of this axis, and that these are just some of the variables that might be involved. So what I'm proposing here, and this is not unlike some things that I've heard here today, is that in the context of someone who's been diagnosed with breast cancer and then over time, the experience of the treatment and all of the emotional distress that goes along with that, over time, there begins to be this disruption in the HPA axis. And women who have gone through this experience while they're under treatment, they usually feel very physically poor. They are also feeling very emotionally poor. And over time, I think these patterns begin to spiral downward. So their diurnal cortisol pattern gets disrupted. We've seen that it's not atypical for a woman, especially metastatic cancer, to be put into a position where her cortisol diurnal patterns are no longer having that little peak in the morning and then a nice drop off through the day, but over time they get flatter and flatter, and then that flat pattern gets lower and lower, and there's very little stress reactivity. So there's sleep disturbance, there's fatigue, one of the more chronic and ubiquitous consequences of breast cancer treatment and the time even during recovery. Sedentariness sets in. A lot of women before they get breast cancer are overweight, and you add to it the sedentariness and pattern that continues during that time. You see inflammation kicking up. I'm just giving a couple examples, IL-6 and CRP. We see insulin resistance, and we see leptin resistance, all of these things working together to create problems with hunger management and eating behaviors. Now you go down the other side of feeling emotionally poor, and the immediate emotional distress that occurs, the feeling that one gets when they first get diagnosed continues on, and then the fears that go on throughout the time of treatment. One of the things I've seen a lot and heard more of, and see it in the literature also, is this body dissociation. It's like, I'm just not, I'm not cool with this, and I'm just going to check out. And I've heard women describe that quite a bit, and when we get them into some of the interventions that we work with, it brings them back into their body. So this certainly changes for women, and then their energy intake, their emotional eating can get kicked up. So all of this goes towards adiposity, an increased BMI, a poorer body composition. And so this is just one model. A lot of things are left out of here. I think that it'd be very easy to see how chemo brain could be put on this map someplace, that the cognitive functioning declines. Name many of the kinds of things that were talked today. They end up on this map. And this isn't just breast cancer survivors. This is many people who go through some kind of traumatic stress that could land with overweight or could land with many, many other health consequences. So I'd like to give another example of where things seem to fall apart. Early childhood trauma has already been discussed extensively today, and child abuse. So we know that the trauma, loss, abuse, neglect, these are very prevalent in the population with early childhood trauma, that for a large proportion that have even just one event, there's a dose-response relationship to early childhood trauma and behavioral problems later, as well as the consequences of health problems. So psychiatric diagnoses, stress overload, physiological health indicators, and then addiction is actually fairly much more common with this population, leading to risk factors for death, including tobacco use, obesity, and on down the line. So what do we do about this? Let's look way back in time at how early cultures may have worked with these kinds of chronic issues, how community and storytelling in the cultural context has made a difference in changing people's lives over time. And the work that's been done most recently with storytelling is mostly in the context of working with changing behavior now in health contexts. So some of the ones, have you seen some of the research out there on storytelling? And what kinds of things have you seen that we've been able to change? Yeah.
CDC did this intervention, they educated children, so children educated adults on healthy lifestyles. I think it was
Using storytelling?
Yes.
Okay, I'm not familiar with that one. I'll have to read about that. On particular lifestyle issues or just across?
Yeah, it was, I think it was for Native Americans.
Yeah.
And in the tribes.
Oh, okay, good.
So people, the
Yeah.
adults didn't listen obviously to what's happening, but children are very
Yeah.
open to different
Great.
stories.
Oh, cool. All right. Thanks. Yeah. Right.
Massachusetts has been working with low-health literacy populations down in Mississippi for chronic uncontrolled hypertension.
There you go.
I just really love this intervention where it's very short videos of different patients just talking into the camera. This one lady's got her hair all askew, she's wearing a t-shirt saying "Born to be bad."
Right. So this is something that is becoming more and more prevalent. We're seeing more literature around the issues of storytelling to change very specific, like lifestyle behaviors, and in this case, the one that I'm probably give as the best example out there of a really solid randomized control trial is Houston's work looking at controlling hypertension. So in my own work, I've done a couple of different ways of working with storytelling, both in the clinic setting where we had videos that were compiled stories that were using stories from the population that we work with and then compiling it into a single story. Papa, he's got to go get this screen. It's around colorectal screening, and the daughters are all up and worried about it. In the end, you find that, yes, he had a polyp, but everything's going to be okay now. And then they learn about why that was so darn important. And in another setting where we worked in the community and worked with promotores who told stories within the context of the educational sessions. So we created almost like a serial story, a lot like the novellas, the telenovelas, and very emotional, a lot of relationship stuff going on so that you get hooked. And you got to come back next week to the class in order to get the next installment of what's going on in the story. But we really found some powerful effects of these stories. One of my weaknesses as a researcher is I always love to create some kind of control group. Everybody gets something really good, and our control group did well too. But in the end, we found that it was the engagement that seemed to make the most difference in whether or not people changed their behavior and maintained that behavior change. It's been a really important part of the work that I've been doing around the issue of behavior change, but I don't think that it necessarily gets at the deepest levels of what we need to be working with. It has the potential for doing that. And so here's where I've made a shift in thinking about looking at how narrative may work in a different way, deeper than the way the story does. And the story just obviously has, if you identify with the story and you see people in there that are doing things like, oh, I could do that too, the role modeling, the identification, the emotional engagement. Sometimes the suggestion is there that the emotional engagement helps you to bypass a lot of the talk in your brain that would say why you wouldn't do it. It just like carries you away. The transportation into the story may carry you into it. And I think there's a lot of power to those stories. Yet, I think that there might be an underlying factor that we have not reaped the potential of, and that is where storytelling allows us to engage with the emotional content of what somebody is sharing, if they're really sharing at a deep level and disclosing information that might help us more deeply understand what might be at the root of what's keeping them from changing that behavior. So in this model, this is actually this first part of it is based on work that we've done on developing a model of narrative as culture-centric health promotion. And then we kind of go off course and start looking at some other factors to look at not just behavioral outcomes initially, but also what happens in the emotional realms to change it. And so the mediators here are with a story that's going to really have the power to make a difference. You've got the emotional engagement and absorption. You have identification with very personal and with cultural elements. And then this is a really key piece here, is that we're seeing that the emotional expression of the person telling the story helps the listener to get more free and open about their own emotional expression and then their emotional acceptance. Because it is that I'm not sure it's okay to feel this fear and the tied up in that emotional ball that seems to keep people from being able to move forward and then behave in a different way. And that the emotional processing rehearsal piece processing also allows a vicarious rehearsal. So imagining what I might do or say in the future could help with this also, which then we see produces emotional processing, somatic reintegration, and then creating an opportunity for emotional well-being and enhanced capacity for behavior change. I've got a small piece of data from a pilot study where we showed a series of videos called Women's Stories, which are women from a multicultural panel of women sharing their stories about their experience of being diagnosed and then making their treatment decisions and going through even all the way to intimacy issues and how do you talk to your family about this. Women watching this early on in their diagnosis were shown to have really reduced emotional distress during the time of their treatment. So we've got a little bit of evidence in working with this model, still developing this. So the storytelling experience, just to take a look at what some of the opportunities might be here. How does seeing others cope simulate the social rehearsal and the vicarious connection? Might there be something in this that really helps us to manage, not just change our behavior, but manage our emotions around these issues? And then what if storytellers can then connect the dots from their underlying trauma to current behavior? If the underlying trauma was just a diagnosis of breast cancer, it's a little bit easier to see how that translation would be made. If the underlying trauma that's keeping me from quitting my addiction is a bigger issue, it might take some work to really capture those kind of stories, but help people to see how someone else, even with the kind of background, even with childhood abuse, if they're able to share their story, that someone else may be able to respond to that as if it were a therapeutic intervention. What if telling stories, just going deeper than how I changed my eating behavior, actually relives and relieves the trauma? Like an example would be from planning how I shall eat differently and hearing a story about that might be changed dramatically if the story was what was about understanding and discovering what was I really hungry for and getting to those deeper spiritual and social needs and being able to share that in a story. How might that impact others in their reception of that? And then if a story has deep human roots in the telling, how might it reach the listener? So we've got bits and pieces that we're doing with storytelling. Most of what I've done is captured the stories, package them, and then share them so that they might change behavior. And we're now looking at how the storytelling changes not only the listener, but the teller, and working in contexts where we've got bone marrow transplant patients telling their stories, and what does that mean for them to share their stories, and then sharing those stories with those who are going into treatment. We've got the same thing going on with American Indian tribes in Navajo land, working with, living with HCV. We've got a group up in Massachusetts who is working with young women who are, have gotten pregnant at a very early age and sharing their stories about their lives, not just the story about their lives being very young parents, but most of them came from the kind of background where there was abuse, there was alcohol and drug addiction in the home, very, very radical backstories that moved them into this situation. And what does it mean to share their story, as well as to tell their story, as well as to somebody else to listen to their story? So I'm going to switch to another topic here, another way that I've been working with and discovering how there might be some deeper roots that can address that dang elephant. I've been working now for about 9 years with meditative movement, and we've put together a package that says meditative movement should be treated as a category of exercise, because we have things like yoga and someone did a slide earlier with Tai Chi Chuan. And so, well, what about that Tai Chi Chuan? Is that the same as Tai Chi Chuan? Is that the same as Tai Chi Easy or Easy Tai Chi? Or there are a whole lot of practices out there that could be considered meditative movement. And if they include a body movement or a posture, some focus on the body, something that includes a clearing of the mind and a meditative state, along with a focus on the breath to achieve deep state of relaxation and tranquility, then you've got meditative movement. And we have a publication that really describes how many of these have similar roots, and that in our understanding of how these work, kind of like in the old days when they came up with the idea for aerobic exercise, so we didn't have to test each one. If you got some aerobic exercise, it's going to count for your cardiac health. In this sense, we're looking at how many of these different practices can work together. Well, what is it that is going on with these practices that might make a difference? I'll just share briefly what is Qigong. How many of you knew the word Qigong before I got up here a few minutes ago? Okay, so there's still a lot of folks out there that are not familiar with that term, but it's like the great-granddaddy of, or great-grandma of Tai Chi. So Tai Chi brought together many of these very, very primordial movements and practices that are simple, that help you can get into them very easily and quickly because the teaching is simpler than those long choreographed steps that are taught with Tai Chi. And yet most of the research done in this country with Tai Chi has been reduced down to very simple forms. So Tai Chi easy, Tai Chi cha. We're taking Qigong-like movements, Tai Chi-like movements, and repeating them. And it's easier for people to learn and quicker to share. So the Qigong is this ancient Chinese practice, including the movement, the meditation, the breath, also has some self-massage techniques. And Tai Chi is a type of Qigong. It's using the series of choreographed movements. Okay. So a number of years ago, a colleague and I, actually the founder of the Integral Institute of Qigong and Tai Chi, who he's like the practitioner and I'm the researcher, and we've partnered on a lot of things together. We did a systematic review, a comprehensive review. I wouldn't call it systematic, of all the randomized controlled trials up until 2009. I published it in 2010, of the kinds of things that we see as a result of practicing these. And what I've done is listed out a number of the things that even have been done since then. At that point, there were 67 randomized controlled trials. Now there's over 120. So the field is moving very fast. And so we see that Tai Chi and Qigong, these practices together, help significantly with symptoms, including pain and fatigue and many other symptoms. Right now we're exploring whether it helps with peripheral neuropathy. Psychological outcomes, anxiety, depression, you can pretty consistently see in the literature these are very common outcomes of these practices. Also helping with intrusive thoughts. Cardiovascular benefits, I can't find a Tai Chi study that doesn't show that blood pressure is reduced. Bone density, there's a surprising one. Why in the world would these very simple, slow movements make a difference with bone density? And there's a theory in traditional Chinese medicine why that might be working, but we're not doing, resistance training here. So there's some positive, significant effects on bone density. And then also we're finding it's not consistent, but we've been doing reviews of the literature to see how Tai Chi or Qigong may make a difference with weight loss. Very seldom are the studies done with weight loss as the goal for the study. It's just kind of like, oh yeah, well, we checked weight as a by the way. And so sometimes the studies don't even have people who are overweight to start with. Well, you're not going to lose a lot of weight if you're not overweight. Those are the kinds of things that we're looking at and finding that if the study has overweight participants to start with, and if the study has specifically designed it to look at weight loss, that we do sometimes, more often than not, see a result in that. So the interesting thing for me about this comprehensive review is that it covers an awful lot of symptoms. It covers an awful lot of issues. And I start wondering, well, it's going to start looking to people like we're thinking this is some kind of snake oil, right? It's like, how can you get all these different results? And in fact, in our study that we did with breast cancer survivors with Qigong, we got this result with fatigue that was significant, but we also got this surprise. This was a by the way result. That's why we started looking at the weight loss issue. Is that our control group that did the same amount of physical movement and activity, they gained weight, where our Qigong group lost the weight. And so with that, we've begun to propose more about why and how meditative movement might work on weight. And again, if you remember that first slide that I shared with all those different pieces, it sounded like the mishmash of everything that we've been talking about today, and then some, that we looked at how and why meditative movement might be working. And I would point you to this central piece here with the blue letters, emotional self-regulation. we have seen in the literature, and now I'm involved in a much larger 5-year study with breast cancer survivors and fatigue, but we're also looking at weight, and we're looking at emotional self-regulation. What is happening internally that might make that difference? How does practicing this make a change in body awareness? And where might we be able to reduce the stress? And so we do have the biomarkers, the first 2 biomarkers listed up here. Diurnal cortisol slope we're taking as salivary measures, and inflammatory cytokines we're taking as blood measures. The rest we're not doing. We probably need to apply for a supplement and see if we can get those measured as well. But because the study was designed around fatigue, those first 2 were the more important ones. We're seeing that this might be a really critical piece to look at. There is a possibly beneath this, I want to say this is not a snake oil solution, but that there is possibly something that is like a latent variable underlying it. And that is what I've been questioning and trying to understand for a long time. And where I've settled in on, because of some work that I did, I mentioned earlier that I have a son who came to us attachment disordered when we adopted him, had fibromyalgia by the time he was 13. He's 20 now, and some of the things that we learned to help him with were mostly about self-managing and emotionally regulating his own internal environment. And we did it through a biofeedback piece of equipment that is not called biofeedback by the manufacturers of it, but the system that they teach really is like a biofeedback system where you hook up, get a picture of your heart rate variability rhythm, and then manage it until it gets to a place that is representative of a balance between the sympathetic and parasympathetic in the autonomic nervous system. So I'm sure you're familiar with the concept of heart rate variability. It has to do with the beat-to-beat intervals, and that it should be changing all the time, that a really strict equal heart rate is not a good thing, and that if you look at how heart rate varies over time, it could be in a chaotic pattern, or it could be in this nice gentle rhythmic pattern where it increases slowly and then decreases slowly, increases and decreases. Does anybody know what else this particular pattern is called? Respiratory sinus arrhythmia, yeah. So that's an inhale and that's an exhale. And if you don't have a whole lot of autonomic nervous system activity, gas pedal on, brakes on, all of that stuff going back and forth, if you don't have a lot of that going on and you're at a very centered place, then your heart rhythm patterns look like this. And so when we get to that conversation later on about what might be a central core measure, I would suggest that perhaps these emotions and heart rhythms might be something to look at. There is high correlation between the chaotic version of these rhythms of heart rate variability, and it also inhibits brain function, and that when you get into this respiratory sinus arrhythmia, these nice deep sine wave patterns, this pattern of coherence is associated with positive emotions, optimal performance, optimal brain function, and interestingly, people who are trained to use this pattern of coherence over time are able to get much better ratios of cortisol to DHEA. And so I'll leave with that. I had a couple of other ideas really to look at how these tied up things in our stress may make a difference by entering in just about any way. You might bring in a heart rate variability coherence training. You might bring in physical activity. You might bring in stories that make a difference, and that the multiple entry points each have the potential for leveraging something to break up this constellation of patterns that seem to occur over and over, whether it's childhood stress that started it or later adult stress or a combination of them. So seeing through the forest, this is where we'd like to go in the future. Once off course is very difficult to recorrect this, but looking at the different entry points that may make a difference to really reaching to a deeper level and resolving that, and looking at perhaps assessments that may help us to do a better job of not only learning about what to measure that might be core, but using it as feedback. thanks to a couple of the storytelling projects that have been funded are up here, but NIH has been very good to us. And then the most recent one is working with meditative movement.
So sadly, the microphone has died. So, and also we've kind of run out of time. So one question before lunch.
Yeah, I have more comments and questions. First of all, as a teacher and practitioner of meditative dances, I want to put it on your map as well, because you mentioned a lot of things but forgotten dances. This is a very important thing.
Dancing?
Dances.
Dancing, yes.
Yes.
And
We
I do work
practice
with a
it.
couple people that do
Yeah.
mindful movement, dancing, and Qigong actually gets very much
Qigong
that
is
way.
part of it, yeah.
It gets
But
spontaneous.
also, I think the main breakthrough for me is here that you combined it all, meditative movement, instead of studying every specific modality separately. I think this is awesome. And thank you so much for starting with the energy exercise.
Thanks. Sorry, it took a little extra time. Just a comment, in our work with breast cancer survivors and meditative movement, that the experience we see so often happen right in the first few sessions, they begin to slow down, they begin to feel that they're back in their body, and the tears come, or the shaking comes, and then there's a story. There's something that came to mind, and they share it, and it's released, and then they can move on. And we want to see what are those biomarkers associated with that.
I'm just curious with the storytelling, how much you think the secret sauce behind that is about vulnerability and acceptance in one's vulnerability. You know, there's been a lot of news around vulnerability recently, and so I was just curious your thoughts on that.
I didn't use the word vulnerability, but I so get it. That is, that is part of it, is the softening inside, the being ready to feel your emotions, accepting your emotions, sharing your emotions. And I didn't talk a lot about the social impact of that in meditative movement or in storytelling, but I think they're very powerful. So I think vulnerability is tied up in that social piece. Yeah, thank you.
Okay, thank you, Linda. While we've had a lot of sharing and retweeting of this morning's proceedings, what we don't have are direct messages or questions. So you have lunch off. If there's a very nice cafeteria across the atrium, it's perhaps with the best food on campus, definitely better than the one in Building 1, where Francis Collins gets to eat. So you can eat there, you can eat in the courtyard, you can come back in here, so long as do as you'd like until 1:15, when Michael Balboni will open us up with the first presentation. And so we'll come back to the video cast then as well. Thank you all very much. Back to our theme of self and others. One topic that we often try and measure in our health research is religiosity, spirituality, the connection to a power higher than ourselves. It's something that we've worked on as researchers and program directors for years. And I think one thing we can agree on is there are better ways to measure and account for that. And I can think no one better than to help us do so than the Reverend Dr. Michael Balboni. Michael.
All right, well, thank you very much. It's great to be here. I think I need to qualify myself by saying I can think of many other people who would be better than myself.
I asked the Pope, but
well, he's busy. He's busy right now. Also qualify to say I work within end-of-life care and advanced illness, particularly with cancer patients, not in chronic illness or in self-management, so you just have to take everything I say with a grain of salt. I'm going to try to quickly cover 4 out of 5 questions. If there's time or if there's a question at the end, we can go into the 5th question. But briefly, what is religion and spirituality? Is it important within serious illness? How should we or may we measure religion and spirituality? And then a little bit of some thoughts about religion, spirituality, and self-management. And then should health scientists measure religion and spirituality? Some more ethical questions we can briefly touch on if we want to. But first, let's go into defining what is religion and or spirituality. Sociologists have, since Durkheim and Weber, have recognized that religion is a pervasive and powerful social force around the world, but it has been very difficult to define. Its difficulty has been among sociologists, among religious scholars, and that's not only for the concept concerning the concept of spirituality, which has been a newer concept, that goes for the concept of religion, which among religious scholars there's been no consensus over the past 100 years of what religion exactly is. There have been typically 2 main approaches to defining specifically religion: substantive and functional definitions. Substantive definitions typically hinge around a particular object, such as God or the supernatural. And so if you want to know what religion is, it will typically have some kind of substantive component, whereas functional definitions, particularly following Emil Durkheim, have recognized that religion has some sort of function or causes something, such as what Durkheim's thesis was social cohesion. The reason why I think religion and spirituality have been very difficult to define is, I think, can be helpfully illuminated through the language of prototypical terminology, or what some call family resemblance. So consider the concepts of a vehicle or fruit or a bird. Now, these are concepts that at their core, we all generally know what they are. So if I put up a picture of a bus or a car, we'd probably unanimously say, yes, these are vehicles. If I put up a surfboard or a blimp, there would probably be much disagreement on whether these sorts of objects were vehicles or not. And that's the nature of a prototypical terminology. We know what a certain thing is, and yet at the boundaries, they are very fuzzy. And this is probably the same within religion and spirituality. If we talked about Christianity, Judaism, Islam, I would imagine we would almost all agree, yes, these are certainly religions. If we talked about Buddhism or Confucianism, there would probably be, and there has been, much more disagreement on whether these are religions or not. And so the very idea of the term is fuzzy in and of itself, which is why I think it's been difficult to define. Another closely related issue, especially within the health literature, has been religion and spirituality, where some want to see a strong distinction between religious concepts and spiritual concepts. I would argue, along with sociologists of religion, Nancy Ammerman, among many other sociologists of religion, I think prefer and take this position. She argues in a journal article, Spiritual but Not Religious, in the journal The Scientific Study of Religion, most empirical evidence indicates, at least in the United States, perhaps also in some other countries, the general way most people conceive of religion and spirituality is that they deeply overlap with one another. Most use the concepts not in mutually exclusive ways, but in some form of partnership. This is where the empirical evidence lies, as she argues. And she also indicates that those who prefer to make an argument that spirituality is distinct from religion, she argues are really doing so out of moral and even taking a political position. They're trying to differentiate themselves from religion for some reason or other. There are those who don't like organized religions, and they want to say, well, this is spiritual but not religious, and it's better than. There are others who are deeply religious, conservative, fundamentalists, evangelicals, for example, who would say they're spiritual but not religious as well. And they want to differentiate themselves from those who are practicing religion out of some rite rather than from the heart. And so people would tend to use this to differentiate themselves for distinct reasons. But the empirical evidence is the vast majority do not think of religion or spirituality as mutually exclusive terms. They're porous. So what is religion? I like the idea of thinking of religion as, again, it's a typological term. There's family resemblances. We're going to see feature characteristics that will generally clue us in that this is a religion or not. I would defer to the religious historian Martin Marty from the University of Chicago, probably the preeminent historian of religion of the 20th century, who noted 5 feature characteristics of religion. There's a focus on the ultimate concern, roles for myths and symbol, reliance on rite and ceremony, behavioral and ethical obligations are typically included, and there will be some level or presence and role for community. I would just note that the first one, ultimate concern, different people will usually use different terms, and at least in my mind, there's slightly different emphases for slightly different reasons, but it's the overall the same as the general idea, ultimate concern. Ken Pargament prefers the term the sacred in identifying what religion and spirituality are referring to. Others want to use the term meaning or purpose or connectedness. This is not common, but I prefer the idea of the chief affection, which is more, it comes out of the Augustinian tradition, in which it's not so much about the head, it's more about the heart and what someone loves, chiefly loves, and that's how we begin to identify what religion and spirituality are. So that's just very briefly a cursory description of defining religion and spirituality. Let me move to the second question. Is religion and spirituality important within serious illness? And I think to the degree that serious illness is analogous to chronic illness, and I think there's probably many analogies, the data that we have, much more data that we have in advanced illness would probably be applicable, but still needs to be studied within chronic illness conditions. Most studies have found that 2/3 to 3/4 of patients in the United States say that religion and spirituality is important to them within their illness. It's important. It tends to be more important to the degree that the illness becomes severe. People turn to spirituality and religion when they're facing serious illnesses versus a broken finger. And there's been plenty of research in general showing that religion and spirituality increases as people age. Let me just very briefly think of one study that my wife Tracy and I helped lead in Boston at 4 Boston hospitals. This was a survey-based cross-sectional study of patients with advanced cancer. We consecutively recruited them into the study, and we had a 73% response rate. Among many questions, we asked them, has religion or spirituality been important to your experience with your illness? And since this is supposed to be more about thinking about research and conceptualization of religion and spirituality, for all the participants, we defined what we meant by religion, and we also defined what we meant by spirituality. I don't necessarily stand by these definitions today as we developed these, I think, in 2005. But in a later slide, I'll argue that this continues to be an important thing, that if you're going to ask about religion and spirituality, you need as researchers to define it. In this particular Boston-based sample, the median age was just under 60 years old. The vast majority of Boston patients are white. Like Massachusetts, 47% were Catholic. Over 70%, almost 80% are either Christian of one tradition or another. 43% indicated that they were moderately to very religious, and about 70% said they were moderately to very spiritual. Now, I'll remind you that Boston is not the buckle of the Bible Belt, so this is what we're seeing in Boston as of 2007. I think we'll see higher numbers in most other parts of the country, exclusive of certain cities such as New York City and San Francisco and a few other places. Well, has religion or spirituality been important to your experience of illness? 78% of our sample indicated yes. We then asked them in an open-ended way, how has religion or spirituality been important to your experience with your illness? We tape recorded these responses and then analyzed them through qualitative means and identified 5 main themes in which we identified that spirituality and religion was important to their experience of illness. The largest theme was coping. Patients talked about how it provided a means for perseverance. Even among these patients who had metastatic cancer, many of them continued to believe in a promise for cure, which gave them hope. Patients talked about spiritual practices, especially prayer. Some talked about religious service attendance, but as patients get older and sicker, religious service attendance drops because they're unable to go. So individual personal spiritual practices increase within advanced illness. Patients talked about religious beliefs that were particularly important to them and helpful to them. They mentioned, again, this is just in response to this open-ended question, how has it been important? They talked about a belief in God's will, that providing a way of understanding and giving meaning to why they have cancer, as well as hope in an afterlife. Many of the patients talked about their cancer as being a catalyst for their own transformation in their lives. Some talked about cancer being the best thing that had ever happened to them because it provided a way in which they now saw what was really important in life. And whereas before they were living in a dream world, as one person said. And some talked about the importance of community. So that gives you a sense of some of the dimensions or domains or subdomains within religion and spirituality, at least as it is appearing as a phenomena within the United States, particularly within a Boston population. I'm going to go forward. There we go. We also asked these patients, we gave them a checklist, a yes or no, whether these have been a spiritual or religious issue for them. And here we found that 21% said they were questioning God's love during their experience of cancer. About 10% said they believed that the devil had caused their cancer, which interestingly was the sole religious or spiritual concern that was associated with a positive psychological quality of life, which we understood to probably be implying that it gave them a way of understanding why they have cancer, where blame can be given for their cancer, and it gives them a sense of meaning. Just under half said they were seeking forgiveness of oneself or others. And then finally, just emphasize, 1 out of 5 Boston cancer patients believed that their cancer was somehow a punishment from God, which I think is really interesting. So it is important. It is clearly playing a significant role within advanced illness. It's likely has some kind of analogous role within many other chronic illnesses. As I've listened to some of the earlier talks, I certainly had thoughts and ideas on how religion or spirituality might be playing a role within these different patient populations. Well, how do we measure religion and spirituality? And I was passing around a little book there that I don't know if you want to pass around the table. In the clinical context, if you're dealing directly with patients, you want to have a fuzzy, ambiguous definition for religion and spirituality. You want to ask open-ended questions as you're engaging the patient. But when you're doing research, it's critical to have very clear definitions for religion and spirituality. Failure to define religion and spirituality to the patient population that you're surveying will inevitably compromise the meaning of the results because no one really knows what they meant by religion or by spirituality. So it becomes incumbent upon the researcher to provide a definition, even if it's a definition that you're not exactly sure is true. At least we have some sense of what is actually being measured. There are some spiritual, religious measures that are out there that tend to blur into existential and other quality of life dimensions. And so they're measuring spirituality, but they're also at the same time, they end up measuring some dimensions of mental health, some dimensions of other quality of life. And thus it becomes, when you're looking at religion and spirituality as a predictor of certain outcomes, it becomes tautological of other mental health issues. So it becomes really important to differentiate religion from certain other, especially mental health and existential outcomes. The FACIT-SP is really a good example of this. I discourage anyone to use this particular measure because it really, other researchers are really saying the same thing at this point, that these certain measures that are out there that are validated are really blurring definitional lines. As we think of critical directions in the study of religion and spirituality, again, it's a young field. There's an importance to go from description towards intervention. I suppose it's not really necessary to say that to this group, but I think it's important for researchers of religion and spirituality really to remember that this is the goal. There's not much sense in purely describing how different phenomena relate to one another. I don't think that's all that useful. We need to be asking specific religious and spiritual questions with always having the eye on what is an intervention going to look like if we have this particular information. Obviously, clinical outcomes are critical, such as measuring quality of life, other mental health outcomes, medical decision making, medical utilization, costs, and having enough information about potential confounding factors in order to factor those into one study. The best place to begin is the booklet I'm passing around. It's been created by measures created by the leading researchers in 1999, measuring 12 different domains. It's well validated. It was validated in the General Social Survey in 1998, and I think it remains probably the best place to start if you're going to think about measuring religion and spirituality. At the end of the book, which you can download as a PDF online, there's 38 questions kind of bringing together all of the different domains. It's critical that we move from generic questions of religion and spirituality, such as these two from the MMRS. To what extent do you consider yourself religious? To what extent do you consider yourself spiritual? And move towards more particular questions. And I want to begin to illustrate this by turning to the Coping with Cancer study led by Dr. Holly Ferguson, now formerly at Harvard, now at Cornell. This is an NCI-funded multi-site prospective study of advanced incurable cancer patients, and the purpose was to examine specifically psychological and social factors within advanced illness, with spirituality and religion as being really a secondary aim. At the baseline measure, patients were asked, to what extent are your religious or spiritual needs being supported by your religious community? There were 5 response options, and in our analysis, we said not at all to a moderate extent was low religious community spiritual support, and then to a large extent or completely was high spiritual support. And this is our predictor. The outcomes in question were receipt of hospice care in the last 7 days of life, receipt of any aggressive end-of-life measures, including going into the ICU, being resuscitated, ventilated within the last 7 days of life before death, as well as dying in the ICU. And these were all information extracted post-mortem. Patients were just under 60 years of age, 37% were minorities. Patients' Karnofsky performance status was 63, indicating they were a pretty sick patient population at this point. 68%, and again, this was New England, Texas being some of the main sites for the study. 68% said religion was very important to them, and 43% responded to that baseline question, indicating that their religious or spiritual needs were largely or completely supported by their religious communities. In our multivariate adjusted analysis, we adjusted for various confounding, including all the basic demographics, race, whether the patient had received an end-of-life discussion, whether they were in a northern or southern recruitment site, the level of trust with the oncology physician, as well as the patient's own religious factors. And here's the raw analysis, and it was very surprising. These results are published in 2013 in JAMA Internal Medicine. We found that patients who are well supported by their religious communities were less likely to receive hospice, that's the blue bar, and among specific patient populations, for example, racial or ethnic minority patients who said they were highly supported by their religious communities, they were even more unlikely to receive hospice. Similar findings regarding receipt of aggressive care in the final 7 days. Those who are well supported by their religious communities were more likely to receive aggressive care in the last 7 days of life. And those who were well supported by the religious communities were much more likely to die in the ICU versus those who said that they were not well supported by their religious communities. In the adjusted odds ratio, you can see that about patients who are well supported by their religious communities were about 2.5 times less likely to go into hospice, 2.5 times more times the odds of receiving aggressive care. You know, and I find this very interesting. There were almost 6 times the odds to die in the ICU versus patients who were not well supported by their religious communities. This is some cost analysis that we've never published on, but you can see that there are significant differences between those who are well supported by their religious communities and those who were not. So those who are well supported by religious communities in this particular study receive less hospice, more aggressive care, more ICU deaths, and they cost more. Limitations to this particular study, it's prospective, but it's not a randomized study, so there might be potential confounding that we're not aware of. This is a U.S. study. It's a U.S. phenomenon, and it's taking place almost the entire patient population that was recruited was Christian. And we don't really know what is a mediating religious community spiritual support. And in answering this last question, we hypothesized that there are potentially 4 different theological domains that may be driving religious community spiritual support to receive more aggressive care and be less likely to go into the ICU. I'm going to take you through these in a particular study that we haven't published on yet, but we randomly selected religious clergy leaders from around the United States, randomly selected them from 368,000 houses of worship in the U.S., oversampled blacks and Latinos. And in this the results I'm going to show you very briefly, we've had a 60% response rate among clergy, with just over 1,000 responding. So we asked clergy to respond to 4 different scenarios regarding a patient who makes the following statement to them. We've stated that this patient doctors have said they're extremely likely to die within the next 6 months. To what degree do you agree with this statement made by the patient? So the patient says, because of my faith, I don't need to think about future medical decisions, such as having a do not resuscitate order or use of breathing machines. And 28% of clergy, to some degree, indicated sympathy with this question, with minorities being more likely to endorse that versus white clergy. Having a do not resuscitate order is immoral. 11% of clergy endorse this. I accept every medical treatment because my faith says to do everything I can to stay alive. This is a question we're trying to measure the sacredness of life and how that might be impacting medical decisions. Here you have a majority of clergy endorsing this perspective, with minorities being minority clergy being more likely than white clergy. I would be giving up on my faith if I stopped cancer treatment. This is a more kind of a hardened position, so a lot less clergy endorsed it, but still a few. And then I believe that God will cure me of this cancer. Here you see that the vast majority of clergy are significantly see this as being something that that they agree with. And we even changed this question. We originally had it, I believe that God may cure me. We found that every clergy member was willing to agree with that. So we tried to make it a harder position to take, that God will cure me. And we still had clergy to some degree in receiving this. And I must endure painful medical procedures because suffering is part of God's way of testing me. Again, about 27% of clergy to some degree endorse these. Point here is I'm giving you an example of theological beliefs, so moving from general religious or spiritual questions to very particular religious or spiritual questions, because this is where pardon the lingo, this is where the money is, where we can begin to engage and potentially intervene for example, with clergy and potentially with patients regarding what is believed and how their beliefs are being applied to medical decisions and medical utilization at the end of life. Big takeaways here are going towards particularity in measuring religion and spirituality, ensuring that you are accounting for confounding factors, looking for medical outcomes. These theological beliefs among clergy are correlated with end-of-life outcomes. I'll skip over that at this point, as well as being able to build towards an achievable intervention. Well, just very briefly on self-management, there isn't a lot of work that at least I've been able to see. Harvey has done a qualitative study on religion, spirituality, and self-management, and she published 3 studies in the late 2007 to 2009. These are qualitative studies. Probably the best thing that's been done has been done by Harold Koenig at Duke. It's a prospective study of depressed older patients with pulmonary disease, and they found that patients who were deeply involved in religious and spiritual practices, such as going to religious community services, praying, reading scripture, were significantly more likely to recover from depression more quickly than non-religious or spiritual patients. And there's been a little bit of some other work that seems relevant. If I can just begin to play around with some ideas, these are just my own hypotheses. My wife Tracy and I were sitting around a lake in Maine a week and a half ago, and we were brainstorming. Okay, how would religion or spirituality potentially be influencing issues of self-management? We would predict that potentially it would play a role in either what it call passive or active illness management. So I think there's strong evidence already that religious or spiritual beliefs and practices are correlated with mental health. So we would imagine that patients who pray, it helps them cope better, and having coped better, they're able to manage their illness better. So it's on the line of trajectory of association. More specifically, religious or spiritual beliefs that might call for action and responsibility, such as a belief that life is sacred. So if life is really sacred, God says it's really important, I need to do everything I can to take care of my body. Among Christians, the body is a temple of the Holy Spirit, and since the body is that temple, one must take care of it. But we can also imagine how spirituality and religion, particular beliefs, might delay or defer action in self-management. So for example, waiting on God for a miracle, God is in control, not me, God is judging me for my sin. These would be different particular religious or spiritual beliefs that may have this effect of delaying management. And I'll stop there and just take questions. I think we have 1 minute.
Thank you for your lecture. Besides the individual's religion or spirituality, one thing I've seen a lot in the elders that I've interviewed is the community aspect of the religious experience, and actually kind of like, well, the ladies are going to miss me if I don't come. And, you know, like kind of almost that, again, some of the vulnerability, the sharing, that reciprocity that comes, and that being in and of itself healing. Any thoughts on that?
Yeah, I skipped over this slide. You know, we imagine it's absolutely clearly associated with social support of various kinds. So just it's probably going to somehow mediate adherence in one way or another. Believing that medicine is God's gift will kind of put one in a certain disposition towards receiving medical care. Increasing trust in physicians or in healthcare because they're authority figures and they've been socialized to believe to submit to authorities. Recognizing that one's medical caregiver might be spiritual or religious like them, and having that level of concordance, which we would hypothesize would likely increase adherence. And then the communities themselves playing a specific role, especially a practical role in carrying out social support, whether it's taking them to the grocery store or taking them to a doctor's appointment.
So you didn't get to answer it, but should health scientists measure religion and spirituality?
Yes. Yes.
So to follow up on what you had on the previous slide and what you just mentioned, what about a patient who has a healthcare provider who doesn't share, and which I think is probably pretty common, and might not even want to discuss that type of thing, which I think is also pretty common?
Sure. I mean, that is a common scenario. You know, from the question of as the healthcare professional, if they don't share a religious or spiritual belief with their patient, you know, at least within the palliative care world, the recommendations is that they should ask whether religion or spirituality is important, and then they should find someone, find someone to help them with their religious or spiritual needs. If there's discordance, I would hypothesize yes, but there's no evidence in any context that I'm aware of. But in other domains such as race, we know that physicians who are black working with a patient who's black, that creates a level of concordance, and that has a positive. It creates trust and it increases adherence. Religion and spirituality is probably going to have as powerful, if not more of a powerful effect, both ways.
Any other questions?
I'm wondering if you have any information about RS in accordance, not only across the lifespan, but more importantly along developmental stages.
You have to say more what you mean.
Well, I think that if you look at, I don't know, there's lots of development. You could look at Ericksonian types of stages, and that, you know, you've spoken to end of life. These might have been adult patients, perhaps they were parents of children, I don't know. But one might think that they've led a long life because of God and those sorts of things, as where we've heard some information about youth with HIV, disadvantaged youth with HIV, and meeting them along the RS continuum might not be something that would be an antecedent to self-management or relate to an outcome.
I was thinking about that during his talk, and I'm willing. I don't know the literature that well, but I'm willing to bet that religion and spirituality is playing a major role in the negative direction. Go ahead.
So, you know, youth of color with HIV are very religious and spiritual, and yet they feel kind of shunned by their community.
Right.
And I think we've been in a conundrum about what to actually do with that, because it's, you know, while there are some places you can send them to, it's not always convenient.
Yep. It's a conundrum. I don't know if there's no simple answer, but it's a big problem, and it has to get addressed somehow. I bet you many of them feel punished. So what, you know, who's supposed to respond to that? It's a big question.
Getting back to should health scientists measure religion and spirituality, one would think that the health scientist would need to be comfortable in that area, put it that way, to handle the difficult questions.
Yeah, I think so. So, working in interdisciplinary teams, I think, is absolutely key. Working with clergy, as the direction of one of our studies is going, the issues really lie among minority clergy, evangelical clergy, Pentecostal clergy. So if we're going to engage those particular types of clergy, we're going to have a team of educators who can sympathize and relate to and identify with clergy of that nature. I don't think you can do this sort of work unless you have that level of concordance. If you want it to be successful, absolutely.
I hear concordance, but health practitioners and healthcare researchers ask human beings all sorts of personal and or intimate details about their lives. We have no reservations asking them about sexual practices, bodily functions, what's your sugar today? Did you take your medicines for thus and so? I don't see why we would have a problem. I don't know that our problem is simply asking questions about God as we define her, him, whatever. I think perhaps we simply, unlike other phenomena, we lack an agreed upon language and scales to ask those questions. And our discomfort is not with the divine. Our discomfort is how do we ask those questions? How do we operationalize it in a consistent way? And what I think I heard from in the middle of your talk, Michael, I could have been wrong, and that's why I didn't tweet it, is it... There were people who were writing during lunch, and I wasn't there. I feel so guilty. I'm going to have to go to confession after. But seriously, did you say that it is one way to help us get there is if we, in our research and or care, provide an operational definition of religion and or spirituality when we talk to patients or research participants?
No, I said the opposite.
Okay.
I said, when dealing with patients, be ambiguous and open-ended. When doing research, for scientific purposes, you need to remove the fuzziness, and you need to come down on a very clear definition of what you mean by spirituality or religion. If you leave it open-ended so that spirituality could be theistic, it could be compassion, it could be human existential concerns, we don't know what we're talking about for research purposes.
And then the Fetzer book is one way to use reliable and valid measures in research, not care. Correct?
That's correct.
Okay.
Yep.
Yeah.
This was a research talk.
So I can somewhat speak. Hi, my name is Darcy Graves, and I actually used to be a faculty member at a medical school in Kansas City. And the Templeton Foundation has actually funded a lot of medical school curricula around the subjects of spirituality and religiosity, but it's teaching physicians how to take spiritual histories and using those more vague terms, using things like Pacholsky's FICA, what is your faith? How do you want me to use it? Do you have a community? And those sorts of things. But to get to the comfort level, as part of my medical school faculty-ness. I was teaching how to do spiritual histories using the, what gives you meaning sort of spirituality, because the students were very reticent about these sorts of things. And after they would work with their patients, they would have to report back and do a reflective essay. And I had a student write, I did not ask this patient anything about their spiritual history because I deemed it too personal. I then proceeded to do the anal exam. And so I think there are some things that still need to be worked upon. But, I had my students shadow hospital chaplains as part of their communications homework. They had to figure out how to ask open-ended questions and all of those sorts of things. And this was back in 2002, 2003, so I'm sure there's been a lot of progress since then. But there is stuff happening on the medical education side, and but having these operational definitions on the research side is absolutely critical.
So just like politics, we could go on forever, and we won't ask the question about politics. Do we have time for one more question, Bill? Why not? And then we end with the last question.
Thank you. I think, first of all, I kind of felt uncomfortable through the talk because you started with spirituality and religion, and then you kind of narrowed it down to just religion. So I think there shouldn't be combined like this. The second is, just like in Linda's talk, she combined different modalities that provide the same state of being. So she combined meditative movement. I think religion and spirituality also should be combined not by the titles or by the country of origin or by racial thing, but by the effect that this spirituality or religious practice has on the human body, on the human health. For example, there are a lot of spiritual practices or systems of belief that do not have sin or punishment as part of it. In this case, a question about whether I was punished by God with this health issue is just irrelevant. So I think the difference between different spirituality and religions should be done not by the name of this movement, but by the effect it has on human social and health practices. And I wonder if you can comment anything on this.
I mean, it's a complicated topic, but I would, in very brief, I would just say two things, both of which I acknowledge are controversial, and I'm not shy to say controversial things, I suppose. One is I would encourage you to at least look at Nancy Ammerman's article in the Journal of Scientific Study of Religion that looks at the usage of spirituality and religion among people within the United States. And its usage by most people, its conceptualization is that they are porous, integrated ideas. And that's how most people continue to conceive them. Secondly, and this is even more controversial, but I'll say it as well. Candy Brown, a religious studies scholar at Indiana University, came out with in a book in 2012 published by Oxford University Press called, I think it's called Healing Gods or No Healing Gods. She argues that she looks at specific spiritual practices that have been adopted within the healthcare context, including yoga and Reiki and other meditative practices. She argues that these practices are indeed religious, and that advocates of these practices have attempted to distance them from religion, arguing that they're spiritual, not religious, and have framed them in secular terms. And she argues that conceptually and theoretically, all of these practices have religious grounds and continue to have religious theories embedded within the practices. it's an interesting argument. I understand you wouldn't agree with it, but I think it needs to be taken seriously. And it all comes down again to the question of definition. So, thank you.
We're a little behind, though we have one less speaker. Death in the family is led to Laura Shalaha not being able to join us, but another distinguished colleague who is Dr. Perry Halkitis from NYU. So I'll turn things over to him. Do you want to present from there? Or okay, great.
I was thinking a little bit about the conversation. Maybe this is a good transition to what I'm going to talk about now, but this notion of the role of religion on people's health, and I think we've spent some time this afternoon thinking about it on the individual level and not thinking about it more on the socio-political level. And as for somebody who studies the health of gay men for the last 20 plus years, I can't help but think that the actions of people like Kim Davis, who use religion to fight against marriage equality, are detrimental to the health of gay men. And I'm going to talk a little bit about that today. When Bill asked me to do this talk, I wasn't really sure what I was going to do. I'm not really sure what I'm going to do still, but I'm going to try to string it along for you somehow. I have slides. At least I have slides. And I thought, like, what does he want from me? Now, as I said a moment ago, I have. It's either going to be great or it's going to flop, right? So, there's no gray area here. I've been studying the health of gay men first around issues of HIV for some 20-something years. Now, more broadly, HIV within a larger context, just because of the evolution of the epidemic. And when I was speaking to Bill, I was thinking, like, what is it about my research that speaks to like self-management and health? And I gave it some thought, and I realized that what I think I do in my work and what I hope I do in my work, which I think speaks to these particular issues, is understanding health issues from a framework that is a biopsychosocial framework, and two, then doing research that really lives on the hyphen of theory and practice. And really, I know that most people in this room probably believe both those things, and love the idea of a biopsychosocial perspective and love the idea of doing work on the hyphen of theory and practice. But I don't think research often really implements these things. Sort of like, we talk about a multidisciplinary perspective. How many of us truly do that really, really well? Let's be honest, right? But we use the word a lot. So I pushed myself and I thought, let me think about, I use these terms all the time to describe my work. Does my work really do this? So what I'm going to do is just talk briefly about these ideas and then illustrate to you from my work what I think is an evidence for me espousing this idea and actually implementing it in my research, and then somehow translating that to self-management. It's all tied together with a very fine thread here. So let me start by talking about this. And I love this quote from this article. I just finished writing a chapter. One of my areas of research is on HIV and aging. I wrote a book a couple of years ago about the life experiences of long-term survivors. And I've been recently writing a chapter about the psychological health of older adults living with HIV. And I love this quote from this article that says, optimal HIV self-management must be framed within a larger context that simultaneously addresses HIV and comorbidities while considering how social and cultural factors uniquely intersect to influence older African American women's self-management strategies. I believe that completely. And I think that, in the last, several years in the HIV world, there's been this whole movement to the biomedicalization of prevention, with this notion that, we're going to find people who are HIV positive, we're going to put them on medications, they're going to be virally suppressed, surprise, only 30% get virally suppressed. And then we're going to give PrEP to all the HIV negative people, well, the young gay guys don't know where to get it, and they're going to take it every single day, and we're going to eradicate the AIDS epidemic. Thank you, Governor Cuomo from New York. But we know the fact of the matter is that any health condition is not just a biological phenomenon. It is a psychological phenomenon, and it is a social phenomenon. And so when we think about it from that perspective, health is something that espouses all of these areas. And, it is the reason we think about health as and problems with health as illness as compared to disease. Using a biopsychosocial perspective is one that moves away from a simple pathogen-centered approach to health and well-being to a much more holistic approach about health and well-being. And so in a biopsychosocial perspective, as you all know, we think about the biological factors for sure, but also with their intersection with the psychological factors and the social factors and how these three relate to each other and influence health. And that's sort of just a little summary chart here for you. This Institute of Medicine chart, I think, actually illustrates it very beautifully, where you think about these concentric circles with biology in the center and going all the way out to eventually local, national, and global policies and politics. And thinking of, and going back to the point I made earlier, this issue, and I don't want to underplay it, this issue that discrimination is a factor that undermines health is something that we really need to think about carefully in this room. It is not simply about behavior, right? If it were simply about behavior, everybody would be wearing a condom all the time, and everybody would be taking their pills, and there wouldn't be an HIV problem in this country. But in fact, as I wrote a few years ago, discrimination and homophobia are the factors that are fueling the HIV epidemic in this country more than anything else, more than simple behavior. And so that's why I really love this particular visual. And it's very evident in the ideas presented in this Institute of Medicine report. One of my favorite agencies in the whole world is the Terence Higgins Trust in the UK. And this is a model. They are way ahead of the curve here. This is a model that they developed, I think, in the early 2000s to try to think about the AIDS epidemic in their populations, which looks very much like the AIDS epidemic in our populations. Which is an interesting phenomenon, a whole other interesting phenomenon. National Health Service, which is our health service, and we're getting the same outcomes here. But this particular model does, I think, a very nice job of showing that even things like community businesses and media have an impact ultimately on HIV incidence in our country. And policies, obviously, and social services. And behaviors are there, of course, in the center, but behaviors in themselves are not enough to explain health states. And here's a nice family. So I'm going to talk to you now. It's not my big Greek dysfunctional family, but it's somebody else's family. So I'm going to talk to you now a little bit about a study that we've been doing for the last 7 years that we refer to as the P18 cohort study. And this is a study that's been funded by the National Institute on Drug Abuse. And it was a study that was first funded in 2009. And we have been following a cohort of young men, gay, bisexual, and other MSM. I know that seems like a mouthful, but if you just say MSM, it shortchanges the importance of sexual orientation in health matters, right? So I'm a gay man. I'm not an MSM, right? And we have been looking at that, both the development of health problems and resiliencies over time, and looking at very much at biological, psychological, and social factors that drive those health conditions. And God bless NIDA, they funded us again, and now the guys are 22 to 23, and we've opened up the cohort, and we're following them, and we do full-on STI testing, and we do HIV testing each assessment. They come in every 6 months. It's like for some of them, they're home away from home. For some of them, it's where they come and do their health checkups instead of going to a doctor. So we're looking at multiple areas of health states, and it's the study is directed by a theory of syndemics. And for those of you who may not know it, this is a theory that was first developed by why am I blanking? By somebody at the University of Connecticut whose name I can't remember right now. But anyway, it'll come to me because my executive functions are not functioning right now. Meryl Singer. Thank you. And then has been a theory that many of us doing HIV behavioral research have undertaken over the last decade. And basically the theory of syndemic says that where you see one health problem, you see other health problems. That when you show me a mental health problem, I'll show you a substance use problem. When you show me a substance use problem, I'll show you a sexual behavior problem. These health problems don't exist in isolation. And in fact, they're synergistic, and they fuel each other, and they make each other worse. And that's one part of the theory that I think is completely true. And then the other part of the theory that I also think is completely true is that there are psychosocial determinants that drive these health states. That individuals and groups that experience more inequalities, that experience more levels of discrimination, more stress because of their minority status, have higher levels of burden, and as a result, ultimately have worse health states. And Merrill Singer developed this theory in the early 90s because he was trying to explain the HIV epidemic in Hispanic women in urban areas, and why was it that this particular population was so affected by the disease. But we who have been doing work with gay men have sort of taken this and run with this theory. So this is what this study is really trying to get at, which is looking at the drivers, the malleable drivers, because that's what I always am interested in, the things that are changeable, right? And so to develop interventions that can affect the outcomes, the health outcomes of these young men. And in fact, recently, thanks to the lovely NIH again, we got funded to do another study, which is added to this study, an ancillary study on HPV, because these young men in our cohort are not vaccinated for HPV. We know that there are high rates of anal cancer in gay men, especially HIV-positive gay men. And if these young men continue to seroconvert the way they're seroconverting, I'll show you those numbers very soon, then anal cancer is a possibility for them too, right? So we just got funded to do genotype testing to determine to see if they're exposed to any of 9 strains that could possibly cause cancer, oral and anal cancer in their lives. So stay tuned for that. So here is, again, another way of thinking about the theory in a paper that I wrote with my colleagues, Rich Walitsky and Greg Millett, that basically looks at this endemic health problems in this population, thinking about it in this very holistic way: substance use, mental health, violence, and sexual abuse, STIs, HIV. One of my doctoral students is developing a beautiful portfolio of work on intimate partner violence in this population, which is really understudied. And then looking at the biological influences, the behavioral influences, and the psychosocial and structural influences which affect these health states. Okay, so after the first 36 months, we tested every single man as they came in for HIV antibodies, and then they had an HIV confirmatory test, and then we linked them to care and what have you. And so at the beginning of the study, there were 600 men, and there was a prevalence rate of 1%. At the beginning, 6 men were HIV positive. So 594 men were HIV negative at the first baseline assessment in like 2009, 2010, 2011. And so we wanted to see what are the factors that explained incidence in this group of men as they progressed over time. And what we saw was that after about 3 years of follow-up, we had 43 seroconversions, which is a cumulative incidence rate of about 7%. So 7% of these young guys, by the time they were age, now, what are they, 18 at 36 months, what is that, 3 years, about 21 are HIV positive, right? And what is it that is explaining this about, why? Like, we have knowledge, we have education, we have condoms, we have PrEP, why is this still happening? And so we started to look at all of these factors that potentially drive this. And here's some things that is not surprising, but I don't think really helpful. So, okay, so the black men are much more likely to become HIV positive than the white men. Okay, but any epidemiological study will tell me that. More interesting is the fact that men who were lower SES had a higher likelihood of seroconverting than men who were higher SES. And in fact, when we started to sort of tease it apart, when you started to look at the white men and the black men separately, and you sort of split them up by SES, it seemed like SES was the factor. The race factor sort of just went away, right? It was SES. So that was an interesting finding, right? But perhaps even more interesting was the fact that these young men who were seroconverting also tended to live in neighborhoods with higher levels of HIV prevalence, uncontrolled viremia in their neighborhoods. Right? And while not significant, you see a trend that they also tended to live in areas that had higher poverty levels. Right? Getting with me where I'm going here? And in fact, when I show you this on a map, so here is a map of New York City. What borough is this? Quickly. Very good. Okay. We still wonder why it's a borough, but it's there. Here is the poverty level, and the darker areas are the higher poverty levels. And hopefully this is going to work, but it doesn't seem to be working. Come on, man. Oh, there you go. And there, and with the red circles, are the young men in the study who seroconverted. Okay? And if I show you the next picture, which is HIV diagnosis, darker red, higher rates, again, you see a very similar pattern. And then here's people living with HIV, and again, a very similar pattern. Okay? Now, that's really, really interesting. If I actually, I had another chart in here that I took out because I thought it wasn't relevant. If I actually showed you a prevalence of HIV in New York City, where people were living and where people were dying, you would see that in the very rich neighborhoods, in like Chelsea and Greenwich Village, which are down there at the tip of Manhattan, they're not dying. But in the Bronx and in central Brooklyn, the poor neighborhoods, they are dying. Right? Okay. So what does this tell me? What does this tell? Is this right? Right. What does this tell me in terms of the work here? So, in terms of self-management, how does this all relate to it? I think it reinforces the ideas that that researchers and clinicians need to espouse this biopsychosocial perspective that places the person at the center, right? That realizes that the person comes into the health situation with lots of realities, right? And that we cannot ignore these realities. Religion being one of those realities that they come to the healthcare situation with. And if we do that, we're going to fall short, right? I was having a conversation with Bill before about New York State's End of AIDS program, and it has three basic components to it. Number one is identify people who are HIV positive, put them on treatment, because they'll get suppressed then, because people take their meds every day, you know that, right? And then give PrEP to people who are at risk. PrEP, does everybody know what I'm talking about? In case you don't, pre-exposure prophylaxis, use of one antiviral once a day right now, injectable versions a few times a year coming down the way. The problem is that these young men in the study who don't go to the doctors, they don't go to the doctors at all. They tend to present when they have a problem, usually a sexually transmitted infection. Yet we expect that if they're going to take PrEP, they're going to be seeing a doctor every 3 months. I don't know. That's the kind of structural stuff that I think is a huge problem. So in summary for this first point, if we seek to empower individuals with a tool to manage their own health, we must attend to the realities of their lives and the multiple levels of factors that shape their well-being. Part two, the intersection of theory and practice. And so here's a quote from my book, 2009, about meth use, where I write, any impact on the proliferation of methamphetamine addiction will be most successfully realized if researchers work with practitioners to address the methamphetamine problem. Change will come about if all of us, researchers and practitioners, move outside of our silos, our own comfort zones, and build on the common ground at the intersection of research and practice. And I like to think that I really believe that, and I really do that, right? So I do not do intervention work. We do not do intervention work at our research center. And why do we not do intervention work? Not because we don't want those millions of dollars, but because we believe if we are to do intervention work, we are to do it with a community partner. And so as we are, right now, we are developing a intervention study for older adults living with HIV that uses puzzles to sort of make executive functions better, but we're doing it with a group called Friends Indeed in New York City that serves older HIV-positive adults because we think that's the way it's going to work best if it's taking place in the community. This is no disrespect to people who do intervention research. It's just my own personal belief. So as early as 1982, it was noted that there is a limited understanding of how research findings become integrated into clinical practice. And let's be honest, this is not just true for health or public health or psychology. Education research has this problem, you know, huge problem. There's amazing educational literature out there on what the most effective learning mechanisms are. They don't make it down to the classroom, right? Right. So these gaps between research and practice, it's, you know, one of the things that I think we struggle with as researchers, which is like, how do we really take this work and have it affect people's real lives? And the answer, I think, is by creating teams that marry researchers with practitioners. So at the same time, while we're doing this research, you know, works at community-based agencies are often based on people's life experiences and reactions. Like, you know, at the beginning of the AIDS epidemic in the 1980s, people developed programs that they thought would work because that's sort of what they felt, right? And there wasn't necessarily a theory behind it or what have you, but they put them in place. And truth be told, it's not so different these days, right? At many community-based agencies. And so if we were to think about this visually, you know, there's this enormous disconnect that exists between research evidence and practice, right? And there's a lack of attention often on our part, we researchers, to community groups, agencies, and governments, local grassroots knowledge and experience, which I think can make the research so much better. And this disconnect is somehow made worse by, I mean, we think that we solve this disconnect through some passive dissemination mechanism, like giving out flyers or giving out talks at conferences, right? But the people who we're studying, whose lives we're seeking to improve, don't really come to those things, right? They don't really read behavioral medicine in their beds at night, right? I would. Even I don't read behavioral medicine. My Entertainment Weekly is right next to my bed, right? I'm going to be honest. But when it was a very good issue last week. But when researchers and practitioners come together, great things happen like this. So about 3 years ago, all of a sudden, there was all this attention around older adults living with HIV. And you probably all know that by 2020 in this country, 70% of adults living with HIV are ages 50 and older. That's huge, right? That's huge. All right, so these are 3 examples of some community-based events. The first one here that I actually had the chance to moderate, where the amazing Steven Spinella introduced me, where we had like 500 people who just came to this big auditorium and just told their stories about what it's like to be an older adult living with HIV, and what they needed, and what they wanted, and what they hoped for. And similar things have happened since. One of the great things that's happened as a result of this is GMHC, which is one of the leading AIDS service organizations in the country, I think the oldest perhaps, in the early days had a buddy program. And the buddy program was for people who were really ill. They would have a buddy, and the buddy would go and help clean the house and cook some meals and do the laundry and what have you. And then all of a sudden 1996 came around and people weren't dying as much, and the buddy program sort of faded away. But Sean McKenna, who is this amazing man, who's one of the men I interviewed for my book, really had a battle with GMHC and really encouraged them to rethink this buddy program. So now they've reinitiated the buddy program, thanks to Sean's effort, for older adults. So like a 65-year-old HIV positive person needs a buddy, right? So many older adults living with HIV are feeling isolated and lonely. And so a buddy program seems like a great idea. So we've in some ways we've come full circle with this epidemic. But that happens because events like this happen that bring researchers and practitioners together. And again, another lovely diagram. You know, and in the literature, this is also referred to, I believe, as evidence-based medicine, where we think about the patient's concerns, the clinical expertise, and the best research evidence, and try to bring those 3 things together to optimize the care for the individual. And the value of EBM, according to Dave Sackett, is that the integration of best research evidence with clinical practice and patient values, it enables the development of self-management and optimizes the quality of patient care. And so I'm going to talk to you about another example from my work, which I think shows doing research on the hyphen of theory and practice. You'll let me know. So this was a study for testing, trying to get untested Black, gay, bisexual, and other men who have sex with men into HIV testing. And it was a multi-site study in Atlanta, Baltimore, New York, and Washington, D.C. It was called Project Access in New York. And we came together with an agency. I have 1 minute? No. We came together with an agency called Harlem United, which is a leading AIDS service organization. Like, they brought the expertise from the community, we brought the expertise from research, and we wanted to test what was the most effective way of bringing men into testing, right? And at that point, there was all this controversy in New York City about partner notification, and for years, agencies had been doing mobile vans in places in the park, and we thought there's this other approach called social networking, social network theory, that might work better. And so we came together as a team, and lo and behold, did in fact find that social networks yielded the most positive results. It was the method that was most effective in identifying previously untested HIV positive people. Alternative venues was good, 6.3%, but not as good as the 19.3%. And when you looked at, this is the sexual behavior of the people, when you looked at what explained the positivity, the testing strategy was the most significant factor, with an odds ratio of less than 1, meaning that the alternative venues testing was much less effective than the social network strategy. Okay, so the benefits of linking research and practice, I'm not looking at the back of the room. It supports the use of a community-based approach. It advances the body of science. It demonstrates an effective research practice collaboration, and I think has an immediate beneficial effect on the management of health, both the individual and the public's health. And it's critical that we close this gap. So if we seek to empower individuals with the tools to manage their own health, we must involve them actively in the decision-making. And that can be at the community-based level or at the individual-based level, involving them in our research. Many of us probably have community advisory groups. We probably should use those much more actively in our studies. They can help us guide us with the questions that we ask and what have you. And here's my final slide, that facilitating self-management in patients must be a key objective in healthcare, both in terms of chronic diseases and in terms of lifelong treatment. Efforts to enhance self-management require that we use a biopsychosocial lens, and optimal uptake of self-management tools will depend on the translation of research to practice. Thank you very much.
Are there any questions?
Thank you very much for your talk. So governments tend to fund now evidence-based interventions and spend a lot of time and energy getting those community-based agencies to use those evidence-based interventions. And that's more of the public health, infrastructure. But most of the funding for HIV is, right, it's still public, but it's more in the medical domain. And you have all these research findings, and you always have the trouble of implementing them in the real world, because unless you get public dollars, even Medicaid and Social Security doesn't pay for the types of interventions that researchers develop. And I'm wondering if you have any insights into how to move that iceberg towards implementing actual things that work, into the clinical realm.
So I'll start by telling you, can you hear me? Is that okay? I'll start by responding that my very, very first work in the field, less than 20 years ago, when I was 4 years old, was an HIV prevention study for positive MSM. It was called the Summit Study, and we came up with this beautiful, 6-session, beautiful intervention that was fun, that nobody could afford to do afterwards, and then it sort of went nowhere from that. So what do I think? How do I think we avoid situations like that? I think we avoid situations like that by working in the context of these community-based organizations. Like, they can tell us what they can do, right? I serve on the board of GMHC. There's a limited amount of funds. There's a limited amount of money. Every single penny counts. If we work with them and have them at the table as we're designing these things, we can still do good science. We can just develop a program that then is replicable after we're done. I think that's part of the answer, but certainly not the whole answer.
I think there's another part of the answer, not simply working with community-based organizations, but also working with with clinics and providers and quality assurance and billing people. In my previous life, I was R&D director for the largest mental health and substance abuse agency in South Florida, and so you learn how to be creative, and do Medicaid capitation, and so there can be pieces of interventions or specific sessions that are billable. And so and community-based organizations need funds too. So bringing in those people into the conversation is as important as the community experts. I think and it also will help, and bringing in those people who are involved in facilitating, empowering, paying for care also helps to develop implementable, forgive me, interventions and move those, once those practices are proven to be best or better, it helps move them more quickly into the system because they were developed with those people earlier on.
I think there's we're able to feed that information back to the clinic so that the doctors at least were empowered with some information on their patients. And I think that's another example that's not an intervention of how theory and practice can come together.
Have you had any experience with, or have you thought about, do you see a role for PCORI in addressing some of these issues?
Yeah, probably.
Yeah.
Yeah, I think that's actually a really
Any other questions? Thank you.
In addition to being much more informed, I almost feel like I've engaged in another Qigong session. I feel really energized after that talk and the energizing interchange. Thank you, but it's all Qi. It's all good Qi. Now comes an exciting time where we take our notes and our thoughts and group however, as you are able, because I didn't do any pre-assigning. In your folders, I think in the right side, you will find a roundtable discussion guide. Please meet up as you are so inclined here in the atrium and answer these questions. Perhaps even you were following along and writing down these ideas as to the most important lessons from any or all of the previous sessions. And let's meet back here. It is 2:51. Let's say we start again at 3:30. We go through them, prioritize, come up with some action items, and then send you to the campus shuttles and or your waiting taxis so you can get home at a reasonable hour. Meet you back here at 3:30. Thank you. I don't know if you, as we're settling in, I don't know if, are there any blues fans in the house? Anyone? Anybody like blues, folk rock? One of my favorite artists is Keb Mo, whose picture is up there. His given name was Kevin Moore. Well, it was Kevin Moore, and then Muddy Waters thought he was very, very talented and renamed him Keb Mo. And one of his songs is, you don't have to be perfect, you just need to give me what you got. So your first question is an important fact from your group that you got from one of the 3 sessions, or perhaps you were so fascinated that you and your group couldn't decide on one. Do you want to share any of them with me?
So number one, we like what Dr. Halakidis had to say. Now we talked about, we spent some time talking about the importance of the community and how many of the questions that we had and some of the hurdles and barriers and positives that we had could have been maybe better worked through had we engaged those stakeholders at the outset, which then brought in the religion and spirituality discussion as well, about how some of our own questions and discomfort with what we do with this information should then go back to the original thought of engaging the affected population in the first place, to ask them, how do we incorporate these incredibly important issues into our work to try to help you.
Thanks. I don't have, I'm not sure, I don't know why, I don't have it on slideshow, and so I'm showing this, but what I've written down is, I have 2 points. Start with stakeholders, the people from communities we want to help, and return to communities with results. Is that okay? What else? Nothing? Okay. Another fact from today's sessions. Okay, so, yes, ma'am. DJ, do you have the microphone? Thank you.
Was from Drema's talk about cognitive function and how when it was added to the model, when it was added to the model, SES and race and ethnicity kind of washed out. That was just extremely fascinating to me and exciting. That perhaps there are these other variables that we really need to take into account in our models that we really haven't been taking into account. And that was extremely compelling to me, and certainly something that I want to look at a little more closely. So.
I'll walk you through the thing when we're done, but I have cognitive function, in parentheses, add to the model, and SES falls away, and rethink traditional predictive variables and consider more closely. Pardon? Oh, okay, thank you. Okay, any other? Yes, ma'am.
the person who's receiving the care is engaged in making decisions and in that whole process. And then something that, remind me of your name? Eileen shared was that she works a lot with people who are looking at the cellular level, so pathologists. And I'm sorry, I have this in my hand. And recognizing the importance of the patient level. So it's not just about the pathology and it's not just about the biology and the self level, but also looking at the patient level.
So cellular experts, pathologists must consider at the patient level and the collaborative approach to care, engage patient in all decisions. Okay. Anyone else? Linda?
So I was reminded by Frank's presentation that in my effort to look more within at the self-management issues, that I let down all of my past work that has had to do with social impacts, and that the very thing that had one of the most profound effects in mediating these childhood abuse sequelae was the social influence, the social connectedness of those family and of those around them. So to me, it was just a reminder that even when I think it's so damn complicated to really look within and the things, all the factors that I'm trying to hold in, is that even then I got to make that circle even bigger. That every one of those things, whether it's long past affecting us now, with the constellation of symptoms and issues we're grappling with, that the future has to stay big, including social influence. That was the thread.
Okay. Look within, look without at social sequelae to constellation of symptoms. Olga, you put your glasses up. I thought. We're on the, I guess, the first page, first question. What are the important facts you got out of today's sessions? Then we will get to other lessons. I mean, so this is sort of like David Letterman's top 10 facts that A, you didn't know, B, made you think twice, that kind of thing.
I think one of my important lessons was about spirituality and religion, because when we work with different systems of values, it's also spiritual values and just family values, we have to align our health goals with the value system.
Excellent, thank you. Anyone else? Okay, so what other, were there any other lessons that resonated with you that were your favorite? I'm on just trying to summarize the second question. Anything that rose up in your group or perhaps you wrote down on your sheet? Yeah.
I had expected that the issues of either childhood stress,
Oh, that's wrong.
stress, or later adult stress.
Sorry. Well, that's a way to wake up.
I had expected that whole continuum of stress sources that I focus on in my work would have been an unusual piece brought in from others' work, but I was delighted. I mean, the first thing in the morning, it's like this is central to many of the models. And even if the models are dealing with something like, well, let's take a look at sleep, for example, in diabetes. These are all
Okay, Sarah? Multiple entry points to individuals, others? Anything else? No? Anyone? Anyone? Bueller? Huss? No? McCloskey?
The point that was brought out that we should include as health scientists religion and spirituality. I think Olga brings up a really good point that regardless of religion and spirituality, yes, we should include it, but it's also a value that people hold near and dear to their hearts. And we should be aware as researchers, regardless of whether you're spiritual, whether you have religiosity in your makeup, or whether you're spiritual in nature, what are the values that you have? And that's really something that I think is a clue to what we're talking about here today.
Health scientists must address spirituality. Well, I'll show you all these things. Okay, what else? Okay, moving on.
How you're defining self-management? What are those components?
So there are multiple definitions of self-management. I missed the rest.
Right. So it'd be important when conducting your research that you define how you're defining self-management. What's incorporated? What are the variables that are, my definition of self-management for this study is A, B, C, D.
Hold it. Talk with the other hand.
Great. Anything else? Yes, ma'am?
We talked about, we didn't have a name for it, but this core thing that we thought was important, that could be a key, the elephant in the slides, a key feature that may be possibly necessary for a lot of people to kind of get at this core emotion, kind of valuing of themselves, to be able to then layer these other skill sets and behaviors and new things on top of it in order to maintain this new lifestyle, this new way of being, that there was some sort of core element that needed to be touched on. And some of the narrative discussion touched on that, and some of Dr. Belzer's work touched on that, just that human connection. We don't know what it is, but we'd like to see more work on defining what that is.
Anyone else?
One important point, I'm not going to say it was my most important point, but I do think it was well stated that we had a lot of discussion about the spirituality and the religion, and I think we have an expert here that did discuss the need to understand the definition of what that is when you do conduct your research, and actually had a measure that seemed to be fairly reliable and valid that is worth looking at. But I just think that was an important point that was brought up and should be captured.
Okay, last call. Okay. What lessons have you, that you didn't list already, did you find most useful personally for your own work? That you didn't necessarily list already? Yes, ma'am. I'm sorry, Olga.
One of the lessons, thank you, DJ, that I didn't realize before was that in many cases, using text messages is more beneficial than face-to-face because the face-to-face interaction has more emotional landscape. So when you limit, in some cases, it is beneficial to limit it just to information exchange. And I didn't realize it before. So social media is very, very powerful in this case.
Anybody else? Microphone. Next.
I think, okay, and then the ladies behind you had one. She was.
I just wanted to say there is a really great model called the resilience model, society to cells. So it takes into account all these different levels of our lives by Jessica Gill here at the NIH and Sarah Zanton, who's at Hopkins.
Who needed it?
Resilience model, society to cells. Got it.
One takeaway for me was the reinforcement of the holistic approach to care. Just that happy to hear the words biopsychosocial beings and knowing that that encompasses more than just the specific illness and that there is a lot more that goes along with that. And I did want to say that the discussion where it says prejudice does play a role and impacts care, and that it's very important to understand the person who's the recipient of your care, so that way you can deliver better care, I would say.
I got the biopsychosocial beings. I'm not sure how to type the second part because I was typing. The stress, the prejudice.
No, and just that when you're saying that using the word biopsychosocial, it reinforces my belief in holistic approach to care, but not to forget the piece of your own prejudice when you are dealing with whomever you're caring for, that could be an impedance to delivering the best care. And I thought that was a great point that was raised by the gentleman who spoke about the HIV positive community.
Good point.
Got it.
It's just more proposal than observation, but I also start my presentations usually with energy balancing. I think this is a great tradition that comes from ages before us, when people smoked the pipe of peace. So doing like 30-second or 1-minute meditation or energy balancing is totally awesome for discussions.
EJ?
Anybody else?
Okay. Is there anything you haven't mentioned that you think? I think. Okay. And I don't know, that could be the power of Jeff or Dave. If it is, thank you. I've got, is there anything that you think is useful to others in the room, or is there anything that you haven't mentioned that you want to be certain to share with people back home? Oh. Okay. Yes, ma'am?
I don't want to miss the opportunity to talk about the imaging, the brain imaging that we talked about earlier in the day. I think that was important, and it really got down to the basicness of self-management. So I think that's really important. That's my bias since I'm the center director at NINR.
Okay. Thank you, Dr. Team Lead. Anything else? And something about health literacy? I didn't hear it.
That's what it was.
Oh.
Don't forget that there is health literacy.
Remember health literacy. Got it. Olga?
In our discussion group, we talked about the spectrum of different activities or different states of a person, from self-awareness to self-monitoring to self-management to self-happiness, I guess. And I think it is very important that in our research world, we do not forget about our intuitive part that helps us to maintain this self-awareness, even though sometimes it's very difficult to measure. And the end of the spectrum is total resilience and total health and the state of, like, highest state of being, where we moving toward. So, I don't know, I'll end here.
I think this.
Okay. Oh, go ahead.
I think it piggybacks onto recommendations. So I didn't know if you wanted me to move to that, but I could speak. We were in the same group.
Move to recommendations, because I will. There will be. Yeah.
So basically, our group talked a little bit about, we did talk about the multiple definitions of self-management and how that can be both empowering and also confusing. And at the same time, we would have loved to have seen work with patient-directed goals with regard to self-management. We talk a lot about you need your A1C to be managed correctly because that's what the guidelines say, which is important. But at the same time, what is this 65-year-old with 5 chronic diseases goal? Is this person's goal just to be able to wash their hair? You know what I mean? Or is it to manage all these diseases? And so that, I think it would be very compelling talk in the future to talk about patient-directed goals, even if they don't have anything to do with the person's chronic disease, and kind of see what happens. And I know there's some really interesting research being done around that right now. We had a couple other recommendations, but I don't know if someone else wants to speak first, and then I can.
Got the microphone.
Fair enough. I think the other thing I've been learning a little bit more about is function and functional status and how it interacts with chronic disease. And I've been just blown away by the amount of money people with a functional deficit cost the healthcare system who have chronic disease, regardless of age, which I was very surprised by. And so I think that would be a really interesting talk as well, to include function in the realm of self-management, and how that self-management changes with functional deficits, and just the interplay there, because of how important it is, and also how hard it is to capture that group of people because they can't perhaps come to an intervention as easily or come to a research study. They're much more homebound. So, I mean, these are the people that are costing the most and the most isolated. So I think functional status, even regardless of age, would be an interesting piece to self-management in the future. And I think those were the two big pieces that our group came up with as far as recommendations. Yeah, and disability. I mean, functional status / disability.
I think it's been mentioned as one of the most important items. I think someone mentioned about collaboration, but I think we talked a little bit about using the PCORI model. We've talked about adding clergy to your research team, you know, having the patients there that are self-managing as part of the research team and including the community. So just broadening our model of what we think about the research team to be and who's going to participate in developing these proposals and ultimately could get to some of these patient-directed areas and these harder constructs to measure or to incorporate into your research. And PCORI just has a model that, you know, is using a lot of these different techniques.
Martin, while you're...
Yeah, so we had a recommendation, which is to get the ear of politicians, senators, to continue to recognize the importance of research in this area, and in turn to get continued funding in this area of research.
Because otherwise I would not be allowed to pursue this kind of research at my institution.
Marvin?
So I'm not sure this is really a recommendation. I'm actually looking for feedback on this, but I was kind of taken today by the diversity of areas that people are researching, and that people were talking about storytelling and cognition and sleep and you know a whole bunch of different things that all impact. And I think it's critical research, but then when I think about when we get to interventions, it muddles a little bit, and we really need to think more about, you know, how do we really figure out what works? And I know our group talked a lot about, you know, kind of being a little more pragmatic and, you know, participatory research to kind of get better ideas. But, you know, I'm not really sure where we take this in terms of doing good research, but also doing things that are impactful, because, you know, I took home that, you know, any one thing probably isn't going to be enough. It's just understanding that all of these different things are important.
So
Actually, I wanted to follow up on what Marvin was saying, because I guess one question is, if OPNET is a basic research mechanism, people are really talking about things that are much more clinical and more in the usual wheelhouse of the individual institutes. And so I guess one question is, in terms of your takeaway, what are you trying to get at? Are you trying to get at the really basic kinds of processes that you could look at in a lot of different contexts? Or are you thinking about basic things, maybe with a large number of contexts, but trying to think about what the dimensions of those things would be?
What's nice about OPNET is that one can, because of NIH's structure, one can conduct basic research across a variety of, for lack of a better word, chronic condition, across chronic conditions. And so the sleep, syndemic stress, and then specific disease measures, whether it's viral load, A1C3, asthmatic, need for Ventolin, whatever the disease-specific measures are, certainly can be included, but what we don't know is, and what we saw throughout multiple presentations, were all of these variables on how do these things happen? How does sleep and its restorative nature influence sugar levels, cognitive functioning? How does, and if you don't get enough sleep and Andrew, don't have the right breakfast, then it messes up your sugar, and so what are the different pieces that influence the linebackers crashing in the middle of the day? Perhaps because of a sugar drop or a sugar high, but also perhaps because he didn't get enough sleep, and so the synapses are not firing, not necessarily because of sugar, but also because of sleep. I'm sorry, that's a real sloppy example, but it's those processes. And what do we talked about socioeconomic conditions, race, ethnicity. We didn't mention so much about we talked somewhat about the stress of managing one or more chronic conditions. We didn't necessarily talk about the stigma or associated with being someone with certain conditions that that are reduced but still exist. People who, some people blame diabetics for their lack of control over their own sugar. One could go on. So it's, looking at those effects in different populations can tell us more about the human condition, and apply something that you learn with teens and type 1 diabetes among young MSM in the Bronx or vice versa. Drenna.
So to piggyback on that, something I meant to bring up in my talk, and I didn't make it on my slides for whatever reason, is that I think creative ways to look at some of these underlying mechanisms across populations and even across time, if you want to get complicated. Some of the work that we're doing with the NINR center directors is to try to come up with some core, some common data elements, some key measures, some key concepts that we think could be meaningful across multiple conditions. My center is on symptoms. We also have incorporated new centers on self-management, and there's even some work going on as well to think about how do we make some sort of repository or some sort of way of combining data from all of these studies that have key elements so we can actually answer those questions. But we're sort of doing it with our hands tied behind our backs because we don't necessarily have a funding mechanism to do that. To take, 30 different pilot studies from the last 10 years in my School of Nursing and put them together into a data set where we can say, this issue cuts across all of these different populations, all of these different issues, and these are some ways that we may want to, more questions we have, ways we may want to intervene and what have you. And so it really, I think, takes a new way of thinking and sort of getting out of our silos of populations and diseases and thinking about these overarching issues. Then we can learn so much more and have such greater impact with so many more people if we are able to combine this data in a way that it can crosstalk and we can work with it.
Excellent. And okay. Sarah, Linda, DJ.
So I think on a related note, one of our recommendations was trying to create more of these funding opportunities that cut across institutes so that some of these basic principles of self-management or basic behavioral mechanisms can be examined across diseases or across conditions.
we're giving them the information, but we're giving them stuff. Meditative movement as well, that we're finding that women wouldn't have come into our study if they thought it was not exercise. I'm a couch potato, I can't do it. But it slipped in on them, and then they went from being couch potatoes to joining the gym. So these stealth interventions go indirectly to deeper areas. And I'm giving my two examples. There were others that were used.
Okay. Got that.
The other one that I would love to see is more of the laboratory work that helps us capture and understand what can we find that helps us to measure the things that are at that deep level without having to draw blood and saliva. Draw blood, draw the saliva, and do these other measures and find out what correlates well with that.
Okay.
So whether it's a paper and pencil questionnaire with psychometric properties, or, and my favorite, which I've already shared, is this heart rate variability coherence measure, which that is highly correlated with Shimon state, highly correlated with improving your cortisol DHEA ratios. But can we get more about those kinds of measures? I'm trying to do wholesome neurons on the standards. It's up. It's so easy to measure and capture.
That's great. Thank you. DJ? And then I'll run you through the slides.
I didn't have anything. I was asking if there was anybody else that had something. Olga.
One of the things that I think is very important here for NIH, for us, to embrace other sources of knowledge. Because sometimes, I think we are moving towards this direction, but in addition to scientific knowledge, which is obtained in the lab or in controlled study, we also have best practices out there that help people. And maybe until we test some hypothesis in a randomized clinical trial, we can use, or maybe we don't need a trial after all, we can use those practices that come from generations before us. If we know that people were helped or were able to deal with different chronic conditions centuries before we came to this earth.
Great. Oh, dear.
Anybody else?
Now I have
Didn't hear from the person that was going to be discussing measurement.
Right.
So one of the things that hopefully she was going to bring to us is the need for measurement in self-management. And I know the group that I was speaking to, or cut in on, if you will, we were talking about the need for measurement, and I brought up the fact that there isn't really an overall self-management measure out there that people are using today, and I think that that's something that is sorely needed in this area, is a general overall self-management measurement, not something that is disease-specific.
Okay. I can read you through. I unfortunately cannot make this slideshow appear on the screen. I hope I don't bring the other screen down again. I can read you through this list, or I can send you a PDF and you can send comments. What would you? B. Okay, the answer is B. What I do need to tell you, aside from great and humble thanks for a terrific, stimulating, enjoyable day, is, aside from thank you, safe travels home. If you are an expert panelist that we are sponsoring, scan your receipts when you get to work and send them to me stat. It's the end of the fiscal year, and we have only a few days to get the funds into your direct accounts. And I can send you the link to the blogs, because Linda's is the latest to roll out this morning, and you know where to find me. I'll be here if you need anything on your way out, and you know where to find me by email or phone if and when you need me later on. Thank you all very much. Okay.